Good evening, everyone. I hope everybody's well. Hello. I think I know a couple of people from step one already. Oh, nice. How's everybody doing? Let me introduce myself. I am Charles Faselis. I am the chairman of medicine at the VA Medical Center in Washington, D.C., and I'm a professor of medicine at George Washington. I will be doing a good part of medicine with you. Nice to meet all of you. I will start off with endocrinology, and then I think over the weekend, Friday, we're going to do pulmonary medicine, GI, and I think we're also doing preventive. We got a great team tonight. Maggie's with us, and Dr. Mark and Dr. Aaron. I think we're in good hands because they really do all the work. All right, you guys ready? I'm going to go, I go with the notes, right? If I skip anything, I will let you know, and I always go back to it and make sure we cover everything. This is in step two, right? Step two, endocrinology. It's the first couple of pages in the book. Internal medicine. Everybody okay with that? Page 9, that's right. Everybody okay? All right, wonderful. All right, let's get going. And don't worry, I will, at the end of this lecture, I will have my email. I will forward my email to everybody if people have questions beyond the stuff that we will answer tonight with the text we'll answer. So I want to make sure after we finish these subjects, everybody understands them well. All right, so let's talk about some general concepts about the pituitary. The pituitary is surrounded by the sphenoid bone. The sphenoid bone kind of protects the pituitary. It's in the sella turcica, and it's very important to remember that it's close to the hypothalamus and the optic chiasm. The optic chiasm is very important. Right? So anybody know why that's important anatomically, clinically? I mean, you know, like clinicians, we know a lot less than you guys do about step one. Right? Because tumors, because the vision, because Zia said it could be compressed. And Dr. Arlene said the optic tracts. That's exactly why. So if you have an enlargement of any tumor, right, in the optic, that's pressing on the optic chiasm in the pituitary, you get bitemporal hemianopsia. So Shristi, what's bitemporal hemianopsia? You got your visual field cuts, right? Bitemporal hemianopsia, tunnel vision, right? Like you're looking through, you know, a tunnel. That's right. So I tell the story that this, you know, older man was brought in by his wife, and she said, listen, this guy is like hitting the car to the right, hitting the car to the left. Because when you look at the visual fields on this person, you know, they kind of plot out the visual fields like this, right? This was blocked here, this whole side here, right? And this whole side here. So any tumor in the pituitary could do that if it grows enough and it puts pressure enough. So one of the first things that we do when we examine patients for pituitary lesions, what's very important always to do? To make sure, right, that they could see on the periphery. Okay? Everybody okay with that? So we have to know a little bit more about what the pituitary does. The perimetry, very important, very good. So the posterior pituitary doesn't produce any hormones. Is that statement correct? Doesn't produce, synthesize. Maybe I should use the word synthesize better. That's right. So you guys got it. So they're kind of asking like a trick question, right? Because they don't. Where the posterior pituitary hormones, they're in the hypothalamus. They're produced and stored in the neurohypophysis, right? Right, and the one that that's really important to us, especially in endocrinology, is antidiuretic hormone, right? You see what happened to the slide here? So you got the spell devil here, and instead of oxytocin, it goes OxyContin, right? So obviously it's oxytocin. right? Everybody okay with that? But it's antidiuretic hormone that we are very keen on, right? Because it's very, very important. It stores free water in humans. You're able to concentrate your urine and hold on to free water because of antidiuretic hormone. Very important hormone. So I'll be talking a lot about antidiuretic hormone and a lot tomorrow about the mineralocorticoids because they ask questions about fluid regulation in adults. And if you guys understand those two, we're in good shape. You pretty much understand a lot about these hormones and what happens in terms of water balance in the body. The adeno hypophysis, or the anterior pituitary, makes up about 80% of the pituitary gland, and that's the one that secretes the other hormones that regulate other endocrine organs. So they kind of call the anterior pituitary the facilitator of endocrine organs, right? Or kind of like the quarterback of endocrine organs. So you secrete TSH and you regulate your thyroid. You secrete ACTH and you regulate your cortisol. So a type of hypofunctioning can occur, right? So by affecting the pituitary in certain cases, as well as hyperfunctioning, that's rarer, right? But hypofunctioning, definitely. You have destruction of the pituitary, you don't produce ACTH, you don't produce TSH, you have hypofunctioning. So when we talk about a primary dysfunction in an organ, we're talking about the disease that affects the organ primarily. Like you have, for example, primary adrenal insufficiency. We know that there's destruction of the adrenals. If we talk about secondary, we're talking about typically the pituitary. And sometimes, rarely, we hear about tertiary dysfunction. What's tertiary dysfunction? You guys can walk through this. Hypothalamus, Nada says, right? So primary is the organ, secondary is typically the pituitary, with some exceptions, and tertiary is the hypothalamus. And that's it. Okay? Every time we see a lesion in the pituitary, or for that fact, any endocrine organ, it doesn't necessarily mean that it's hypofunctioning or hyperfunctioning, right? Most findings in the pituitary, most masses, most adenomas are non-functioning adenomas. Everybody understand that? So if I see a MRI of the pituitary, what do you mean no? So most of the lesions, if you take percent-wise, I'm not asking a question. If you take 100 lesions in the pituitary or any endocrine organ, right? If you have a mass there, it is a non-functioning adenoma typically. Everybody okay with that? I'm just saying without anything else. A non-functioning adenoma, right? So a small percent of those are functioning, right? So what does functioning mean in terms of endocrinology? Secretes, very good. Produces something. So production, right? That's what it means. Everybody okay with that? So that's why it's important. When I see something on the MRI in the adrenals, I don't say, okay, this is a pheochromocytoma right away. Most of the times it's an incidental adenoma or an incidental non-producing mass. Same thing in the pituitary. Everybody okay with that concept? Because That's important because of how we evaluate endocrinopathies, right? We always leave imaging for last. Why do we leave imaging for last? Because we want to show some type of endocrine problem, hormonal, right? Before we go to the imaging, because we won't know what that imaging means unless we've proven a hormonally active tumor. Everybody understand that concept? Okay, very good. All right, wonderful. All right, let's go down a little bit further. So we want to talk about two diseases that have hyperfunctioning of the pituitary. Yeah, David, that's really interesting because you know why most people, they get off and they start working up patients. And 80–90% of the time, these are non-functioning adenomas. You know, they got a word for them. They're called incidentalomas. You know, like incidental finding, right? Okay, so let's go back here. So let's go to this case. A 32-year-old woman comes to your office because she's got a milk-like discharge, right? So she's got galactorrhea. All right, so user said pregnancy test. Z says prolactin level. Okay, so those are good tests. Anything else? She's got galactorrhea. Oh, Zia says TSH, right? TSH. There you go. That's one of the right answers, right? And a good medical history, right? Maybe she's taking some medications we don't know, right? So they want you to know how to evaluate patients with galactorrhea. They want you to check a prolactin level. They want you to check a pregnancy test. They want you to check a TSH because hypothyroidism could stimulate prolactin. Not stimulated, it's TRH, right? And then get a good, thorough medical history. Probably LFTs, you're okay with not getting anything else. Those are the 3–4 things you probably should be getting in most of these patients, and maybe some additional stuff in certain cases. But those make up about 95% of the cases. So let's talk about, now we don't need LFTs in this patient. Liver function test, right? We don't need liver function tests in this patient. I don't know. You guys mentioned that. Somebody mentioned getting LFTs. I think you wrote it. See, somebody else wrote it. You wrote it again, and people are following a train of thought here, right? So let's move on. Let's focus here. Right, let's not get off to on a, you know, when you're hearing, you know, hoofs, you're thinking zebras. Okay. So this patient has galactorrhea, right? And we're thinking about hyperprolactinemia. It's a scenario of excess prolactin. In patients that are women, it presents with amenorrhea galactorrhea. So it's important because these patients get not only galactorrhea, and they get amenorrhea at the same time. So they can't get pregnant, right? It's serious for especially young women. In men, it presents with hypogonadism. And it presents sometimes, especially in men, with bitemporal hemianopsia. So the story is that usually in women, they're microadenomas. In men, they are macroadenomas. Smaller in women, maybe because we pick them up early. Maybe because they cause symptoms early and we pick them up. In men, they tend to be larger masses, causing sometimes effects on the optic chiasm, right? Everybody understand that? Guys, if you don't mind, just please, can we focus here? This is not Sheehan's. Sheehan's has nothing to do with this. If you guys want to have a conversation, please, I need everybody to focus. Because people are seeing Sheehan syndrome now, and they're often thinking about Sheehan's. This has nothing to do with Sheehan's. This is elevated prolactin. If you guys got questions in the classroom discussion, send them over. But don't get people off on something. If you don't know something, don't write it there if you don't mind. You could email me as much as you want later. Okay? So let me say this again. So this is excess prolactin. In women, it presents as microadenoma. And it presents with the syndrome of amenorrhea galactorrhea. In men, it presents mostly with hypogonadism, and because probably it's picked up later in the disease, it presents as a macroadenoma, usually with pressure phenomena. Overall, we said if you find an adenoma or some kind of mass in the pituitary, most of the time it's not functioning. But when it's functioning, the most common ones are the ones that secrete prolactin. So a prolactinoma is the most common functioning adenoma in the pituitary. We need to think about a prolactinoma that secretes elevated prolactin as the cause of galactorrhea. We also need to think about some other things, like drugs. Remember, prolactin is under constant inhibition from dopamine. If you have dopamine depleters, then that can cause galactorrhea. It is very common to see these side effects with especially the older antipsychotic effect. And then somebody talked about hypothyroidism. Right? Anybody know what the case is? So it's TRH. It was mentioned before, elevated TRH that causes, right? So you have low thyroxine, high TSH, that's okay. Then you have elevated TRH, right? And it's the elevated TRH, thyroid releasing hormone from the hypothalamus, right? That secretes prolactin. That's the story. Only in very high doses. So we always check about hypothyroidism. They asked about this a couple of times, about the cause of hypothyroidism and galactorrhea. Okay? And then they may also ask it in a different way. For example, they say, you know, somebody who's hypothyroid comes to you and has galactorrhea. You know, what's probably going on with this person? They probably stopped to take their medication or they're taking it infrequently. TRH causes activation of prolactin. Okay? And then pregnancy. You know, pregnancy, second trimester, sometimes can present, right, with galactorrhea. Okay? All right. So the workup is we exclude drugs and hypothyroidism. We exclude pregnancy. We check prolactin levels, right? And if we rule all this stuff out here, right, we exclude pregnancy. We're okay here. Prolactin levels come back elevated, right? And then what do we do next? Now we know we have a prolactinoma. We've secreted, we found it at high levels of prolactin, and we've excluded all the other stuff. So we go on and we image the pituitary with the best imaging study we have, which is an MRI. So the workup of galactorrhea includes make sure the patient is not taking any drugs that are dopamine depleters, make sure we rule out hypothyroidism, we exclude pregnancy, then we look at our prolactin levels. If they're elevated, our next step here is to check and do an MRI and find the mass. After we found it, now we have to treat it. The treatment of a prolactinoma, most of the times it's in women, it's a microadenoma, so it's typically pharmacotherapy. Pharmacotherapy includes dopamine agonists, cabergoline and bromocriptine. In terms of efficacy, both of these are equal, so they're both good. They reduce prolactin levels, they bring back the patient to normal hormonal levels, the amenorrhea goes away in women, and so forth. In fact, because they downregulate the receptors, they usually shrink the size of the tumor, right? So that's important. So pharmacotherapy is the first way to go here. We start with one of these medications. If they give you both choices, the first choice it should be cabergoline, because even though they have the same efficacy, cabergoline has less side effects. Bromocriptine has more nausea, has more some of the other side effects that are seen with these dopamine agonists. So cabergoline here should be first-line therapy. If the patient takes these medications and they don't work, or the patient develops severe pressure effects from the tumor on the optic chiasm, right? Then we consider surgery or radiotherapy. We leave these for last. We leave these for second because look, 30% cause hypopituitarism. You don't want that. It causes panhypopituitarism. So we don't want that. We only want to go to surgery and XRT only after we've given a good trial of pharmacotherapy. So rule out other diseases other than a prolactinoma and galactorrhea by checking TSH, by excluding pregnancy, making sure the patient doesn't take any drugs that are dopamine depleters. Then look at your prolactin level. If it's elevated, look at the MRI and find the tumor. Confirm the diagnosis with the MRI. Now start the cabergoline, right? And then you should be able to treat this person. If that doesn't work, then you got two other options and you have to talk with the patient what's better for them. It's surgery or radiation treatment. XRT is radiation treatment. Okay? All right, so now we want to talk about, we just talked about this, what are the next appropriate tests, a TSH, a medication drug history, a pregnancy test, and prolactin levels. And that's good enough. I'm sure you guys could find other diseases, yes, and maybe cirrhosis may do it and stuff like that, but you should be able to look for cirrhosis clinically rather than having to get all these tests. So we want to talk about another form of pituitary hypersecretion though, and this is acromegaly. Acromegaly is a tumor that secretes too much unopposed growth hormone. Remember, an endocrine disease becomes an endocrine disease when they lose their feedback loops. Their feedback loops are very important because once you lose the feedback loop, that's when this becomes pathologic. So in this case, this is excessive growth hormone. It's non-regulated. If it occurs in children, they grow to giants, right? They're over 7 feet tall and stuff like that. In adults, it causes acromegaly. Unlike the prolactinomas, most of these are macroadenomas. They're large tumors So they tend to be more aggressive, larger. 3/4 of the time, they're macroadenomas. So many times in acromegaly, if you do a good physical examination, if they're large tumors, what should you be able to see on the physical examination? Most of the time, if this is correct, bitemporal hemianopsia. That's right. There you go. So symptoms of pressure on the optic chiasm. Clinically, these patients present with the hands are enlarging, the feet are enlarging, the tongue, the mandible sometimes enlarges. So sometimes the patient says, look, I know I'm 55 years old or something like that, but I've changed, many shoe sizes in the last couple of years, right? So, and this is important because people, adults don't change their shoe size, in 55 years of age. The important thing is that, we sometimes forget it's not only the bones and the muscles and the feet and the tongue, right, and all that, right? They enlarge the organs. And one of the most common causes of deaths, probably the most common cause of mortality in this patient, is congestive heart failure. So enlargement and thickening of the organs, especially the heart, this is the most common cause of death in patients with acromegaly. Right? Also, we need to remember that sometimes they present with bilateral carpal tunnel syndrome. So, the medial nerve, right? So it's affected, thickening of the bone, thickening of the tissue there, compresses the medial nerve. So carpal tunnel syndrome in this patient is typically bilateral. We see a lot of carpal tunnel syndrome now related to overuse, right? But in this case, it's bilateral and it's worse, and it's getting worse over time, right? And this is important for you to pick up and follow that. Look, this is very severe form of carpal tunnel syndrome, and it's bilateral. Also, these patients develop diabetes. Remember, this is a counter-regulatory hormone. So when we say counter-regulatory hormone, we mean it counter-regulates the effects of insulin, right? So they make your sugar go up, growth hormone, epinephrine, norepinephrine, cortisol. So in acromegaly, glucagon, of course. So in acromegaly, about 25% of these patients have frank diabetes. And even higher percent have dysregulations with glucose. So this is important because the same thing occurs with Cushing's syndrome. They may ask us which of these endocrinopathies present with diabetes. And the answer is acromegaly, Cushing's syndrome, even sometimes pheochromocytoma, because these are counter-regulatory hormones. They counter-regulate the effect of insulin. We talked about hemianopsia. We said that could actually be common and early in the disease because it's large and it pushes off the optic chiasm. Not all the time, right? But it could be seen early. If the disease is not corrected, they definitely get hemianopsia. So it's definitely something to look for. The case series in acromegaly tell us that most of the scenarios have been going on for about 9 to 10 years before the diagnosis is considered. These patients, have it for a long time. These tumors are been going on. They don't come to you right away. It's many years later that typically somebody says, look, there's something wrong with this guy, or the person says there's something wrong with me, my feet are changing, my hands are changing, my mandible is changing, and so forth, and they come to the physician. So a chronic disease that has been going on for a long, long time. The way we diagnose it is one of two ways. We actually use both of these just to be on the safe side. We measure insulin-like growth factors. So this is an important test here. They're also called somatomedins. So these are the, actually growth hormone doesn't itself affect tissue. So when you secrete growth hormone from the pituitary, it acts on the liver and it secretes these insulin-like growth factors. That's kind of like a misnomer, because when they were first found 30, 40 years ago, the techniques to isolate them, were crude. So they looked very much like insulin to everybody. So they were called insulin-like growth factors, but they're secreted by the liver. So growth hormone itself has a very short half-life, and it's very difficult to measure. But these somatomedins, or insulin-like growth factors secreted by the liver, have a long half-life, and you're able to measure them. So of course, when I measure IGF, insulin-like growth factors, these levels are very high. This is an important test for diagnosis, and it's also an important test for follow-up. Why? Because if I treat this patient, I would expect the somatomedins to go down, right? If this doesn't work, they're going to keep going up, right? If I treat it and it goes down, I'm doing well. If it goes down and comes up again, it's coming back. So it's a good marker to follow disease activity, right? Very good. And then the other one is the glucose load. So people give the patient glucose, right? So if we give somebody glucose, think about it, we measure growth hormone 1 or 2 hours later, and if I measure growth hormone, right, Sarah says growth hormone should decrease. That's right. You got it. So this patient is normal, right? Because all the counter-regulatory hormones should be down, right? But this guy's a problem, because look at this guy. I give him glucose, and 1 or 2 hours later, his growth hormone levels are still elevated, right? So this guy has unregulated growth hormone, right? So this patient has acromegaly. So most experts do both of these tests just to confirm. They don't want to look in the pituitary, find something. They want to be sure of what they see is an acromegalic tumor. So they do both of these tests, right? Most people like the somatomedins now better because they also allow you to follow disease activity. Both of these tests are probably needed to make the diagnosis, and then we go one step further. Of course, what do? We go and we image the pituitary, right? Because we said the MRI is the best imaging study of the pituitary. So we're going to keep that in mind today. Okay? So what did we say? What are the two tests? The somatomedin levels, which you could measure them randomly, and the glucose load. If a patient has acromegaly, I give them glucose, and what do I see? I see elevated growth hormone levels, right? They're elevated. If they're suppressed, this patient doesn't have acromegaly. Remember I said, for an endocrinopathy to occur, you need unregulated secretion, right? That's what that proves. All right, so now they say, okay, well, you guys found this guy's got acromegaly. Good for you. What do you do now? All right, so the answer is one, depending on what question they ask us. Okay, if they ask us what is the most efficient, right, or the procedure that has the highest efficacy, remember these are macroadenomas, so they're large tumors for the most part, right? So if you take 100 people with acromegaly, what are you likely going to have to do if they're big tumors and they're very aggressive? It's probably going to be surgery. You got to remove, right? Everybody okay with that? So I didn't say that's the best thing, but I said most of these tumors, since they're big and they're aggressive, surgery is the most, it has the most efficacy. Okay? Now, if they're not surgical candidates, right? Then you could try to radiate it, right? So bottom line, it's the most aggressive treatment usually is needed for acromegaly tumors. Typically surgery. If it's not a surgical candidate, then you probably can do radiotherapy. They may ask us, what are medical options for acromegaly? So you got somebody who's older, who has comorbidities, all right? So you got to remember that this drug called octreotide. What's another name for octreotide? Another name for somatostatin. There you go. So you got somatostatin, right? Very good. Somatostatin analog. Where do we use octreotide? What other disease have you seen the use of octreotide? Good. So in bleeding varices, that's the right answer. Bleeding varices. Right? When we talk about GI, we'll talk about bleeding varices. And one of the ways to treat them is to give them octreotide. Okay? Everybody okay with that? All right. So one other thing, if they ever ask a question, is there any other pharmacotherapy for acromegaly? It's not that effective, but the dopamine agonist could actually be used. So some of these tumors have receptors for growth hormone and could be downregulated with drugs like cabergoline and bromocriptine. Right? Not very effective. So I'm telling you right now, this is not the way to go. But, you know, they ask a pharmacology question sometimes. Where can dopamine agonists be used? And the answer is both prolactinomas and acromegaly tumors. Okay? But that's not the typical treatment, right? The typical treatment is it's either you try a little bit of octreotide first, right? And stuff like that. And Jose says about pegvisomant. So pegvisomant is the other one, right? That's a GH inhibitor and stuff like that, receptor blocker, and that has come into play recently. We just don't have enough studies to say how good pegvisomant is. That's why I don't mention it a lot. That's a good step one question, but they can't ask you like, which of these do you treat this patient with? And the answer be pegvisomant. They may ask about a pharmacology question, right? So octreotide first, maybe with some pegvisomant, maybe with some dopamine agonist. If that doesn't work, right, and then that doesn't work, then you got to go to surgery because that's the way to go anyway. Okay? All right, so those are the two diseases that we have to know in terms of hypersecretion. Right? We have to know galactorrhea and acromegaly. We also have to know a couple of things that cause hypopituitarism. Hypopituitarism is very important in certain cases. So this is, remember, any lesion in the pituitary, hypothalamic area can do that. You have tuberculosis there, sarcoidosis, infections, granulomatous disease, craniopharyngiomas in children. That's usually a tumor around that area. They expect us to know that in hypopituitarism, the important hormones are lost last. So if you take a lot of people with these diseases, they tend to lose the non-important hormones. I mean, all of the hormones are important, but they tend to lose some of these that are less important early. GH, gonadotropins, you know, stuff like that. Those are lost early. You know, you don't die if you're missing that. And then last, you lose ACTH. You know, it's kind of like a protective thing. So see, that's important because we check for these early hormones first, GH and gonadotropins, because that's what is reduced first. ACTH and TSH are hormones that diminish later. So kind of like a stepwise thing in terms of decreasing hormones in the pituitary. Right? Everybody okay with that? And then we want to know about diagnosis. Right? So look at this now. We could give arginine. That's one thing that people like. Arginine. Nobody's got arginine. In the clinic. What they do is they give the patient some insulin. They give the patient some insulin. And look at this. They give them a couple units of insulin. And then this causes a low glucose. Right? And then now you guys got to tell me, what would I expect in a normal person? All right, Sarah says GH would increase. That's right. So, right, if GH increases, Sarah, right, you're done, right? It increases. This patient is normal. I'm done. Okay? So I've ruled out hypopituitarism because this is one of the early hormones to go, right? A guy that has hypopituitarism, though, you give them insulin, you drop the glucose, and look at this. Growth hormone is low, right? Now look at this too. What's the other one that could be low that we also measure sometimes here? Cortisol. All right, so you guys got to tell me, why is cortisol? Right, so Claire said ACTH. So this is, cortisol can be low, right? Everybody see that? It may not be low. So remember I said, so you get the ACTH last, right? So it may be early in the disease where you have only growth hormone deficiency and FSH and LH deficiency. So you haven't gotten to the other ones yet. Or it may be severe, right, where you have both of them, right? Everybody okay with that? So the diagnosis of hypopituitarism is how? Causing hypoglycemia and measuring growth hormone levels. If it's low, you've diagnosed it. Also check cortisol, because if cortisol is low, that means this is extensive. Right? Everybody okay with that? So see, we did the opposite of what? Of what we did before to diagnose what? Acromegaly. We did the opposite test. Before we gave glucose, here we gave insulin. See, we do that in endocrinology a lot. We kind of activate or try to suppress, right? Try to suppress the hormone. Okay? So the ACTH goes down last because it seems that the pituitary has more cells to make ACTH, and it's a protective way because it's a more important hormone. Right? So you think about GH and FSH and LH go away early, right? And then these go out last. Okay? All right. Very good. Let's talk about some other diseases and we'll take a break. All right. So I want to talk about 3 quick diseases. All right. Number 1, Sheehan syndrome. You guys should know this well. What's Sheehan syndrome? So it's hypopituitarism, right? Usually peripartum. Peripartum, right? Associated sometimes with bleeding during pregnancy or post-pregnancy hypotension and stuff like that. So we don't see a lot of it now. So some people say maybe it has to do with an autoimmune response. And it's not only necrosis and hypotension, right? So you could see it even when these are absent. You have to think about Sheehan's even when these are absent. It seems to be an autoimmune process sometimes. Right? The first thing that they talk to you about, what does this patient come in with? They may ask you about this, the inability to lactate. So when a patient comes in and she says, look, I was trying to lactate and this is, 3-4 weeks after pregnancy and, lactation has stopped. They said, what is the next step in evaluation of this patient? What are you guys going to say? Good. The answer is check growth hormone, right? After you give the patient some insulin, or what would be another test? Now remember, this is after pregnancy, right? That's interesting. Nicole said check pregnancy. Now that's a smart thing, right? Maybe the patient got pregnant again. So no, so we said growth hormone, right? FSH, LH, and stuff like that, right? Everybody okay with that? I didn't remember. I didn't talk about ACTH. What did I say? You could check FSH, LH, right, and growth hormone. Those are the growth hormone. You have to do it how? After you try to activate it with hypoglycemia, right? Induced hypoglycemia. You either give arginine or you induce hypoglycemia. We'll talk about those two. Okay, very good. And then the other syndrome that you guys have to remember is this thing called pituitary apoplexy. So pituitary apoplexy is a severe form of an acute form of pituitary hypofunction, right? So you got a pituitary adenoma, right? And it kind of grows in there. Sometimes the patient doesn't even know about it. And you bleed into the adenoma. There's necrosis and bleeding out of the blue. So this guy's watching television, like all of a sudden, right? A vessel busts in the adenoma and there's acute bleeding in the pituitary. So what do you do when you have bleeding in your pituitary? You wipe out all the function, right? So this patient comes in with headache, with altered mental status, with confusion, with meningeal signs, because the blood irritates the meninges. So this guy says, I have severe headache in my head, my neck is stiff. What does that sound like? Maybe some fever too. So what's that? Sounds like meningitis. That's what this is. This is sometimes misdiagnosed for. How about the worst headache of my life? What's the other one that it's misdiagnosed for? Subarachnoid bleed, a berry aneurysm bleed. That's right. So one of those two. So this is a disease where it's misdiagnosed a lot. So you got to look in there and see prior adenoma, right? And you got to look at the CAT scan. It says bleeding into the pituitary. What does this patient have? Pituitary apoplexy. Very, very important. Pituitary apoplexy. So this patient has to go into the ICU. We have to give them hormones to stabilize them, and et cetera, et cetera. This is a serious disease. This is, there's not a lot of endocrine emergencies. This is one of 5, 6 endocrine emergencies. All right, pituitary apoplexy, an acute bleed into the pituitary. Clinically presents like a subarachnoid bleed or meningitis. Okay? What's the test to get when you want to rule out subarachnoid bleed? A CAT scan without contrast. Right? That's where you start off with, and then if that doesn't give you the answer, then you do an LP. Right? A non-contrast CT. Right? So be careful. They're going to give you that. Pituitary apoplexy, they're going to give you that. They're going to say bleeding around the pituitary. Okay? Everybody okay with that? All right. Last thing, so we could take a break. All right. We've got 1 minute, then we'll take a break. Oh, let me do it here. So look at here. I want to tell you about a benign disease that you guys get confused about. So look at here. Here's your sella, right? And here's the pituitary, kind of like this. All right. So it's in the sella. It's nice and tight. And right here, you have these diaphragms kind of close off the pituitary in the sella, so the meninges are kept out, right? These anatomic membranes here in most people are there. In fact, 90+% of the people they're there. But in some cases, you're missing this, right? So look at here. So I'm making the bone larger for a reason, because look at here. Look, here's the meninges. See, you're missing these diaphragmatic surfaces, so the meninges protrude in here, and they push out the bone. They enlarge the bone. So if you look at an X-ray, you see like cell enlargement, right? So these are the meninges in here. All right. Now look at here. Where's the pituitary? It's pushed off to the side. Right? There's the pituitary. It's squashed off to the side. Here it is. Anybody know what this is called? What is the syndrome called? So this is like a radiology syndrome. All right. So this is called an empty sella syndrome. All right. Empty sella. All right. Well, it's not really empty sella. What is it? What's in the sella? The meninges, right? All right. It's not really an empty sella because you have a pituitary. It's squished off, right? Pushed off to the side. You can't see it. Even the radiologist with a good MRI can't see it, right? Everybody okay with that? All right. So who knows what endocrine problems does this patient have? For our purpose, for step 2 and even step 3, none. That's the right answer. No endocrine problems. None. That's what I need you to know. None. All right, so why did he get the MRI then? Why did he get the MRI? It's a good one, huh? Why did he get the MRI? Nope, not, well, it could be, right, for some other disease, right? To rule out something else. Like this guy had a headache and they thought he had subarachnoid bleed, or he had, mass in his brain. But that's the point. This doesn't cause headache, right? He got it because he had some other symptom and they were looking for some other disease, right? So if you guys look at some of the old literature, before the age of CAT scans and MRIs, nobody knew about this disease, right? This is a disease where it's picked up because we're doing a lot of MRIs for other reasons. So be careful. Empty sella syndrome, if the patient has endocrinopathy, any kind of hormonal problem, right, it's not the case, right? So you're born, it's a defect. You're born without these, that's the etiology. You're born without these surfaces there, okay? There's no abnormalities for our purpose. I know in some of the literature you say like these patients have a couple things going on. It's probably not true. All right, so you're going to know for the USMLE, these patients have nothing. They are normal, okay? I know they say some people may have an elevated glucose, but they don't know if it's from that or is it just a incidental finding in these people, just because a lot of people have diabetes. Okay? Everybody clear with that? So be careful when you answer this. Be careful when you answer this as an answer. It has to be, the answer is empty sella only when, right, Israel says there's no treatment. That's exactly right. It's only the answer when the patient has no medical problems that are consistent with hormonal defects. Okay, so if they say, look, we found on the MRI that this patient had no All right, everybody. I know. So, Mark, you picked that up. So it took us about a couple of years to figure that out. When phone call comes in, it throws me out for some. Okay. So let me finish this up. Let me finish this up. Yes. So that's the point I'm making. Empty cella is an incidental finding for the workup of something else. Okay? So it's never the answer if the patient has hormonal deficiencies. No complaint, Jose says, no treatment. That's exactly right. Okay? Everybody okay with that? All right, you guys feel comfortable, right? All right, very good. All right, let me stop there. Let's take a 10-minute break and we'll come back at 7:19. How's that? All right? See you guys in 10 minutes. All right, everybody, let's get started. So we'll be going to a little bit past 10 o'clock today. Is that okay? The program says 10:15. We want to make up the 15 minutes from the start. Is that okay? If I see people are getting tired, well, don't worry, we won't go too much over. Okay? All right, great. St. Sarah's motivated. Very good. All right, so I got a couple questions for you guys. All right? I want to rule out acromegaly. What are the two tests to do to rule out acromegaly? So if you pick growth hormone, that's the wrong answer. Good. So the answer is IGF, right? And what's the other one? The glucose load, right? Everybody okay with that? The glucose load and to measure somatomedins, insulin-like growth factors. What's the good follow-up test? That's right. I said you got to do both of them. You got to do both of them. See, somatomedins are very specific, but they may miss 8% of the patients. That is correct. I wrote it in the book. That's why you got to do both of them. All right, so the follow-up test is the somatomedins, right? All right. What's the primary treatment of choice for galactorrhea? For prolactinoma? Cabergoline. Very good. That's the answer. Cabergoline. Okay. What is the treatment that has the highest efficacy in acromegaly? In acromegalic tumors. All right. So probably surgery. All right. Very good. Okay. So I want to talk a little bit about diabetes insipidus, right? And the syndrome of inappropriate antidiuretic hormone secretion. So diabetes insipidus and SIADH are part of problems with antidiuretic hormone. Antidiuretic hormone is the main water-retaining hormone in the body. With the use of antidiuretic hormone, you are able to concentrate your urine and hold on to free water. Why do you do that? So you won't get dehydrated. So it regulates water. Without antidiuretic hormone, you lose free water. You have dilute urine. You get dehydrated. With too much antidiuretic hormone, you hold on to too much free water. So you dilute down your electrolytes, especially the sodium. Diabetes insipidus is a disease where you have either no antidiuretic hormone, that's central diabetes insipidus, or the antidiuretic hormone is not effective. Maybe because you have a problem with the receptors in the kidney. So you need antidiuretic hormone and you need receptors in the kidney for it to function so you could concentrate your urine. If you don't have antidiuretic hormone, you have central diabetes insipidus. If you have antidiuretic hormone but it doesn't work, this is called peripheral or nephrogenic diabetes insipidus. Things that cause central diabetes insipidus are things like infiltrative lesions, sarcoid, surgery, after surgery sometimes, radiotherapy, and after head injuries. CDI is also referred to sometimes as primary, right? Primary. Nephrogenic diabetes insipidus occurs with drugs like lithium and demiclocycline. Those two we have to remember, they're very important drugs for antidiuretic hormone. So they both mess up your receptors. That's right. Dinesh says they damages the V2 receptors. So they mess up your V2 receptors. Lithium, very important, and democlocycline. And then two other things that can mess up your V2 receptors. Hypercalcemia, when your calcium is very high, it can mess up the V2 receptors, so they don't work. And sickle cell disease, they say with multiple infarcts in the kidney, sometimes the kidney then becomes unresponsive to antidiuretic hormone. So hypercalcemia, sickle cell disease, and then two drugs I need you to remember, lithium and democlocycline. Okay? Very good. So they also ask us about making the diagnosis of diabetes insipidus. Oh. Let me make this because I've written, it's frozen, I know. Guys, give me 1 second, I'll fix this. Maggie, can you help me? Can you erase this stuff here? Oh, perfect. Thank you so much. That's perfect. Wonderful. All right. Okay, great. I got my red bit. So we talked about diabetes insipidus being antidiuretic hormone deficiency or unresponsiveness, and we talked about central versus nephrogenic. And these patients, of course, this is why it's called it's called diabetes, because they present with polyuria, polydipsia. They have excessive dilute urine and low urine osmolality, and of course hypernatremia. Remember, if the patient develops hypernatremia, you also have elevated serum osmolality. Remember the serum osmolality, if the glucose and the kidney function is normal, it's roughly 2 times your sodium. So sodium and serum osmolality go together. If you develop hypernatremia, then your serum osmolality goes up. So the question I asked before is, how do we diagnose this disease? And I'm going to go to the whiteboard, and I want to make sure that we understand this. So it's in your notes. So look at this. So you take the patient and you do what is called the water deprivation test. Right? Right. So remember, if you're missing antidiuretic hormone, you lose free water, right? So your sodium goes up and your serum osmolality goes up. But the water deprivation test is very important because it shows you that the patient cannot concentrate their urine. See, here's your serum osmolality on the right. So here's like 250 here, right? And here's 300 here. Right? And then look at here. Here's your urine osmolality on the left, and it goes up to 1,000. Okay? So a normal person, you would see something like this. As you deprive the patient of water, what happens? What do you notice all of a sudden? They secrete antidiuretic hormone, Sarah says, and what do you notice? Right, look at this curve now. That's a normal curve, right? So as the serum osmolality increases, right, what happens? The plasma osmolality increases this way. What happens? The urine becomes more concentrated, goes up, and what does it do? When it becomes more concentrated, it stops the worsening of the serum osmolality. So you're basically concentrating your urine so you won't get more dehydrated. Right? Everybody see that? All right, very good. Look at here. Look at this guy now. What do you notice now? So this line right here, let's do it in blue. See that here? Well, what do you mean no change though? What does no change mean? So speak in terms of osmolality. So serum osmolality goes up to the right. So you're going 250, 260, 270, 300 here, right? See that? And how about your urine osmolality? The urine is diluted. That's right. So this patient has diabetes insipidus. You just diagnosed diabetes insipidus. Please put that in the little table there. Well, we don't know if the kidney is unresponsive. We know it's either the patient has an unresponsive kidney, Kate, or we know that the patient doesn't have antidiuretic hormone, right? So one of the things to do is check ADH levels, right? Or look at this, they just give the patient a little bit of ADH, right? You got ADH, you got desmopressin, and you give ADH, and look what happens now. Everybody see that? What do you notice now? The urine osmolality now concentrates, right? Everybody see that? You gave him ADH, so you could measure ADH, send it out and stuff like that, or you could find out right in the office what the story is. All right, so Dinesh says this patient has central diabetes insipidus. That's the right answer, right? Because they reacted to ADH, right? And then what happens if it's still a flat line? It gets worse and worse and worse and worse. What's that patient have? Despite giving them ADH, now it's nephrogenic. Okay? All right? Now there's a problem with the V2 receptors, right? It's unresponsive, right? Everybody okay with that? So this is called the water deprivation test. What's the gold standard test to diagnose diabetes insipidus? The water deprivation test. In your notes, I've also put a small, you could also measure, not urine osmolality, you could measure urine volume, right? Urine volume goes down in a normal person when you get ADH secretion, when you deprive them of water, right? You should see the volume go down, right? So if you jog or you go out in the sun and you don't drink water, what happens? You don't urinate a lot. You concentrate your urine. All right? Everybody okay with that? Same concept, whether you use urine osmolality or urine volume, same concept. All right? So we have to know this. This makes us understand diabetes insipidus. Okay? All right, very good. So I want to go back here to our class slides, and I want to finish up talking about a little bit about the treatment. We talked about central diabetes insipidus, right? We talked about nephrogenic diabetes insipidus, and I want to talk a little bit about the treatment. So central diabetes insipidus is straightforward. You're missing antidiuretic hormone, that's what we give back. We give something that is very similar. It's called desmopressin. It has one amino acid difference. We give it intranasally, right? It causes concentration of the urine because it acts like antidiuretic hormone without the pressor effects in the heart and the vessels, so it's a good drug. Desmopressin is a very important drug. You guys are going to hear about desmopressin when you talk about hematologic disorders, because desmopressin doesn't only act as antidiuretic hormone, it causes secretion, right, of von Willebrand factor. That's right. There you go. So we give it von Willebrand's disease and mild hemophilia A, right, which is factor 8 deficiency. Okay? Now, we don't like to give too much vasopressin, because if you give it for a long time, it makes your blood pressure go up, it causes bradycardia. So we prefer the desmopressin intranasally. Okay? That's the treatment. Desmopressin intranasally. Now, for nephrogenic diabetes insipidus, it's very interesting, because the treatment is remove offending agent. All right, so we know that. All right, so if they're taking lithium, for example, or they're taking, demiclocycline or something like that, we remove it. Okay, remove offending agent. We give them access to water. Make sure they have access to water, because they get dehydrated really quick. All right, so they try to kind of, whatever they lose, they try to make up by drinking. And then look at this. This is interesting. This is an interesting story. You give them a mild diuretic. I don't need you to know NSAIDs. I need you to know a mild diuretic. So let me ask you guys this. When we give a diuretic for hypertension, what do we expect the diuretic to do? How does it lower blood pressure? There you go. Claire said you lose sodium. So does Zia, right? You lose sodium. So what is diabetes insipidus? It's a disease where you lose what? You lose water, right? Right? So what are you trying to do with the diuretic? You're actually trying to make this person lose a little bit of salt so that this person doesn't develop hypernatremia, right? You're trying to save water in a way relatively by losing more salt, right? And as long as they have access to water, okay? To normalize the osmolality. Very good. See, kind of tricky, right? So this has been asked, because it sounds like a paradoxical process. You sound like, wait a second, why do I give them a diuretic? When this guy is like, peeing like 20 liters a day. And that's what happens to people with diabetes insipidus, right? That's right. Right. So you want them to lose more salt than water. Okay? Everybody okay with that? So the treatment of central diabetes insipidus, right? Desmopressin intranasally. They take a couple of sniffs a couple of times a day. And then nephrogenic, remove the offending agent, give them access to water, make sure they don't lose access to water, give them a mild diuretic like HCTZ or amiloride. Okay? And now we want to say a few words about the opposite. What's the opposite of diabetes, of diabetes insipidus, right? It's this inappropriate, too much ADH, right? Sarah says. And now it means that, look, you're holding on to free water too much. Too much free water. Too much ADH means too much free water, right? So you hold on to free water. So what happens? You hold on to free water, What happens to your sodium? You develop hyponatremia, right? And the clinical pearl that they want us to remember on the USMLE is that SIDH causes euvolemic hyponatremia. Euvolemic means no edema, basically, right? Euvolemic hyponatremia, and I'll explain. So SIDH, right, is the oversecretion of antidiuretic hormone. These patients develop hyponatremia. If they develop hyponatremia, we all agreed that your sodium goes along with your plasma osmolality. So you drop your sodium, right? You drop your plasma osmolality, right? Both of those, for our purpose, go together. All right, so that's what happens in the blood. In the blood, your sodium goes down, your serum osmolality goes down. What happens in your urine now? All right, now this is the urine statement here. All right, so small amounts of concentrated urine, because you're concentrating your urine. Now look at this. If you concentrate your urine and you hold on to free water, look how you measure sodium. It's milliequivalents per liter. So what happens to your urine sodium? It goes up. Why does it go up? Why does your urine sodium go up in SIADH? And this is very important. All right, so Jose says because you concentrate, because you're holding on to free water, right? Yeah, no water. So you're holding on to free water. You're taking it in the body, right? So these are more concentrated urine. So relatively, your sodium is elevated to water. There you go. So be careful because they use, you see the term inappropriate natriuresis, right? They like to use this term inappropriate natriuresis, meaning like, look, you got hyponatremia, and at the same time, you're getting rid of sodium in the urine, but you're not getting rid of sodium in the urine, right? That's like kind of like a misnomer. What are you really doing? You're not getting rid of sodium in the urine. What are you doing? You're retaining free water. That's why. You're holding on to too much water. So you're concentrating. You're taking free water out of the urine. Okay? Everybody okay with that? So what's the sodium in SIADH in the blood? Low. What's the sodium in the urine? High. This is called inappropriate natriuresis, but it's not really natriuresis. It's because it's dilution, or you're holding on to free water. Okay? That's right. Due to increased water uptake, right? You're taking it back into the body. That's what's diluting down the sodium in the blood. Okay? Everybody okay with that? All right, very good. I'm going to say it another way too. All right, so look at here. In SIADH, you got free water retention. It's euvolemic. Remember I said what's the clinical pearl? What's the clinical pearl? Euvolemic hyponatremia, no edema. So you got free water retention, right? You got fluid volume expansion, hyponatremia, but look at here, no edema. See, there's some kind of a mechanism where you hold on to free water and you don't develop edema in this case. It's unclear why, right? No, they don't know, Dinesh. That's actually one of the theories, that there's some type of escape mechanism, but it's unclear. Some people say it's just that you just don't hold on to enough water. It's unclear. But the important thing for us, please, for the USMLE, SIADH is euvolemic, right? No edema. We're going to talk about another disease tomorrow, primary aldosteronism, or Conn's disease. You know, where you hold on to more salt because of aldosterone. That disease also has no edema. So these two diseases we got to remember. Because people say, look, you're holding on to water, right? You're telling us this guy's reabsorbing water. Okay, why don't they get edema? Because of this escape mechanism that Dinesh is talking about. Maybe. You know, this is sodium escape mechanism. It's unclear. Remember that by heart. Okay, very good. So we talked about that. So very important. When do we think about this? Right? When do we think about SIADH? When the patient has hyponatremia and normal volume status. Okay? The blood pressure is normal, Jose, in this case. All right? All right, very good. So, do you guys remember? The symptoms of hyponatremia are irritability, confusion, and if it's severe, seizures, right? Everybody remember what's the symptoms of hypernatremia, the opposite of this? Same thing. Same thing. Altered mental status. So sodium problems present with CNS manifestations, right? Irritability, confusion, altered mental status, and severe, if severe enough, with seizures. Okay, very good. All right. So we want to talk a little bit about the etiology, pulmonary disorder. So I think about three things. I think about lung disease, CNS disease, and drugs. CNS, lung, and drugs. Pulmonary disorders like malignancies, small cell cancer. This can be a paraneoplastic syndrome, tuberculosis and sarcoidosis, lung abscess, even COPD could do it. So chronic pulmonary disorders you have to think about. CNS disorders like head injury and stroke, and granulomatous diseases like sarcoid in the brain and TB. They could also do it. So it's very interesting because these disorders very common to the same causes that cause central diabetes insipidus. Same causes, right? They could do one or the other, right? Yes. So sarcoid can cause DI, central DI, or it could cause SIDH. Very interesting, right? Depending on how it affects the brain and where. And then drugs. Right? Chloropropamide, vinblastine, vincristine, cyclophosphamide. And please remember there's a lot of case reports lately about SSRIs like sertraline causing SIDH. So what are the three categories? Pulmonary disorders, CNS disorders, right? Drugs. Always think about drugs. They have an older patient where they could give you is taking SSRIs and all of a sudden develops hyponatremia. Please think about the SSRI causing SIDH. Take them off the medication, use something else. Okay? And lastly, how do we manage SIDH? Remember SIDH, very concentrated urine and all that business, right? We want to treat the underlying disease. That's number one. Easy things to do is fluid restrict the patient, right, to about 1 liter a day. You know, that's kind of difficult because you tell the patient don't drink water. Obviously, the patient now even thinks about it more and wants to drink water. So that's difficult, right? But we try to treat the underlying causes and we try to do simple stuff like fluid restriction. If that doesn't work, then we go to plan B. Plan B usually means drug therapy, right? Pharmacotherapy. Okay, so you guys remember these two drugs? That's right. So Dinesh says the same drugs that cause what? Nephrogenic diabetes insipidus. That's the drugs I use. There you go. See, I said because those are very important drugs. So I give this guy democlocycline. So Claire said, how about these newer conivaptan and the aquaporins? You guys are not going to need to use those. It is unclear efficacy. Okay, so the only diseases that there's been some kind of literature is if you're taking somebody who has hyponatremia and you're taking them for a liver transplant. Those are probably the only scenarios, right? Yeah. So you're trying to do a little bit of nephrogenic diabetes, insipidus here, right? To treat this guy. That's what you're trying to do. So treat the underlying cause, especially if it's medication, remove the medication, right? Fluid restrict this patient, right? And then if that doesn't work, try democlocycline. Now, I put democlocycline first, right? Because lithium has more side effects. You know, you don't give people, lithium, unless you really have to, right? Everybody okay with that? All right, very good. All right, very good. All right, so here's one thing. You guys always ask me. They've never asked about this, but you guys always ask me. There's some question going around there. that if you have a person with SIDH and severe confusion, convulsions, seizures, all right, this is the only time in medicine, anyway, that you think about using hypertonic saline. So you can think about using it in that patient. It's the only real indication to use hypertonic saline. All right, you got to be careful because you don't want to correct the sodium. There you go. There you go. That's what you're worried about, central pontine meal analysis. That's why people hate hypertonic saline, right? I've seen about 6, 7 cases because of use of hypertonic saline. You're correcting sodium too quick. Remember, it's a devastating disease, devastating, and it's irreversible, devastating. Do you guys know how quick? You guys are going to learn this in nephrology. How quick do we correct sodium? How quick can we correct sodium? Very good. So remember, half of 24 hours. What's half of 24? 12 milliequivalents, right? There you go. So it's about 0.5 per hour or 1 every 2 hours. Okay? If it's totally acute, the experts say you could reverse that right away. The problem is when you see a patient with sodium problems, you don't know how long they've had it. So you don't know if it's acute. So the theory is, so let's say you get some sodium derangement this morning. Okay, I could treat you this afternoon or tonight and change your sodium 20 milliequivalents. Nothing's going to happen to you. It's when it happens over time. See, that's when you get into trouble with pontine meal analysis. Okay? Everybody okay with that? All right, very good. All right, wonderful. Okay. All right, so I want to finish off talking a little bit about the thyroid and general concepts in thyroid diseases. All right, so we want to know that the main secretory product of the thyroid is T4. So your thyroid produces primarily T4, which gets converted in the periphery to T3. T3 is the most potent hormone. That's the one that has the metabolic effects, right? That's the one that has the feedback to TSH. Remember, only the free hormones are active. Now, anybody know what percent of your total hormones are active? Now, this is a good one. Who knows that? So, well, you guys are good. You guys are good. He's really good. So it's like 0.01%, 99.9% is bound to albumin, right? So these albumins are sometimes referred to as thyroid binding globulins, just albumin. So your total T4 is bound to albumin. That's why we don't care about your total T4. We care about your free T4 because that really gives me an idea of what's happening with the thyroid. The feedback to TSH is through the free T4 and the free T3, right? Especially the free T3. That activates or suppresses your TSH. Everybody okay with that? So we don't look at the total. The total, it gets confusing because, the total, because it's bound to albumin, it goes up and down, right? With pregnancy and with, nephrotic syndrome and stuff like that. We don't want that. We want the free. Cirrhosis, that's right. Okay? All right. So a couple of other things. The TSH is the best initial test to diagnose thyroid disease or exclude it. So what they're saying is somebody comes to your clinic and you think they have some thyroid disease, do the TSH first. Because whatever that says, you're pretty much confident that this is what it is. If it's normal, that patient is euthyroid. I'm telling you right now. So they may have the bulging eyes and stuff like that, but this patient is euthyroid. You don't have to worry about thyroid disease if the TSH is normal. Pick euthyroid, go to the next question. Okay, if it's abnormal, then you got some thyroid disease and look at the free T4 and the free T3 to figure out what's going on. Okay? Everybody okay with that? So what's the first test we always look at and we always get when we're thinking about thyroid disease, when we're trying to diagnose thyroid disease? TSH. What if the TSH just comes back normal? Euthyroid. Okay, so listen, I know you guys are smart and somebody's going to send me an email. There isn't a small exception to that. If you have secondary hypothyroidism, the TSH can sometimes be normal. That's very rare and it's not for you guys. Okay, so if a patient has a normal TSH, they are euthyroid. Pick and go to the next question. Okay, very good. You also have to know this test called the thyroglobulin, not the thyroid binding globulins, thyroglobulin. Who knows that? Who knows what the thyroglobulin is? What is it a test of? Good. So Claire says it's released with T3, T4. It's basically a precursor, right? So let's figure out what it is, what it does, and then we can figure out where we use it. So, right, so it circles back. So it's co-secreted with T3, T4, right? Everybody agree? So it's a measure of endogenous T4, T3. Everybody okay with that? All right, so now when do I measure thyroglobulin? So one of you answered already. Why and when do I measure thyroglobulin? Good. So if you're looking at people with hyperthyroidism and you're suspecting exogenous or factitious, right? Factitious. I don't know, they're taking it and they're not telling you. Well, nurses, but doctors too. So let's not, blame the nurses all the time. Like my residents do. Yeah. So Jeremiah says to lose weight. Yeah, I had a medical student like that who somebody sent her some, concoction from some other part of the world. And says if you take this for a couple of months, you lose weight. She did lose weight, but she wound up in the hospital. Right? Didn't even know. She says, I'm not taking anything. Right? Anybody know another reason to measure thyroglobulin? It's very important. Another reason to measure thyroglobulin. Cancer, Claire says. Jose says, yes. So cancer. Why would I want to measure cancer? Thyroglobulin in cancer. Shristi says follow-up. That's the answer. You want to follow disease activity. That's the answer. So when do I do thyroglobulin? What are the two scenarios where I do thyroglobulin? When I suspect factitious and when I follow up thyroid cancer. That's it. Okay? All right. What do you guys know about antibodies and thyroid disease? I know you guys know the antibodies, but what are the two diseases that are antibody related? Good. So the answer is Hashimoto's and Graves' disease. These are autoimmune diseases. They expect you to know they're autoimmune and that they occur with other autoimmune diseases. So you could have Hashimoto's, 10 years later you got pernicious anemia, and you got B12 deficiency, or you got vitiligo, or you got diabetes, or something like that. Autoimmune diseases occur with other autoimmune diseases. All right? Okay, very good. All right, so we got that out of the way. So we said that total T4 and T3 levels are not always accurate. All right? So if we increase thyroid bonding globulin levels, right, pregnancy or oral contraceptives, your total T4 goes up. But that's not, your total T4 is not your free T4, right? So we don't care. So decreased thyroid bonding globulin levels occur in nephrotic syndrome and liver disease. Right? So we don't look at total T4 and T3. Please look at free T4 and free T3 and look at the TSH. The TSH is always telling. Okay. Anybody know what this is? What is this? Good. It's a radioactive iodine uptake scan. So what did I do? I gave this guy radioactive iodine. 48 hours later, I come back, and I know that the uptake, the normal uptake, is supposed to be 10 to 40%, right? I could measure that of the total in 48 hours. Everybody okay with that? All right, so this guy has 85%, right? So what do you guys think about that? 85%. Well, where's the hot nodule here? So this patient has hyperthyroidism. So the radioactive iodine uptake scan, right, shows the direct activity of the thyroid. See, when I check TSH and free T4 and free T3 and all this business, it's an indirect way to look at thyroid function, right? If I ever have a question of what's going on, I go back and I do this. I go back and I do this because it gives me directly the activity. See, I can measure it and look at it. So this guy doesn't have a hot nodule. This guy has diffused uptake throughout the thyroid. Everybody see that? The whole thyroid is homogeneous. It's increased. Everybody see that? So what does this guy have? What does our patient have? If he's got diffused uptake. All right, Jose says Graves. That's right. So I'm asking what type of hyperthyroidism he has. He's got Graves' disease. Very good. What if they say he's got uptake that's high here and another area here? Okay? He's got hyperthyroidism. So now, so Jose says a toxic nodule, right? It's called, when in thyroid terms, it produces thyroid hormones excessively. It's called a toxic nodule, right? Toxic multinodular goiter, right? Everybody okay? It is hot, right? But the term they use is toxic nodular goiter or multinodular toxic goiter. It's a very common form of hyperthyroidism. Well, they call it hot sometimes because it picks up versus an area where it's cancerous when it doesn't pick up, right? But this is toxic because they use that terminology to refer to as a type of hyperthyroidism, right? You see that this area here and here lights up, right? Everybody see that? Right? In Graves' disease, the uptake is throughout the thyroid, right? Diffuse uptake. Here, you got it only in two areas. That's a toxic nodular goiter. Okay, that's a very common form of hyperthyroidism in older individuals. Okay? So when do I use the radioactive iodine uptake scan? Well, I just gave you some examples. When I'm not sure about the cause of hyperthyroidism, I use it to kind of figure out what's going on in the patient. All right, do you guys know any case of patient presenting with clinical hyperthyroidism and the radioactive iodine uptake scan is low? So the patient presents with clinical hyperthyroidism, right? And then the radioactive iodine uptake scan is low. Good. So the answer is inflammation. Oh, the other one is exogenous too, right? But what I was thinking of was subacute thyroiditis or decurvens, right? Because you have the cells are inflamed, right? They're painful. They spill the thyroid hormones in the periphery. Okay? Painful, right? But when you do the radioactive iodine, right, there's no uptake. Okay? So Hashimoto's thyroiditis in the early stages can have that. The problem with that is they don't come to us. They would have the same thing though. right? In the early stages, you could have a hyper state. It would be very mild, and they usually don't come. They come months or years later when they develop hypothyroidism. Okay? Yes, this we'll talk about subacute thyroiditis. It's a very temporary state. It goes away. Okay? Everybody okay with that? No, we don't do this for hypothyroidism. Because listen, hypothyroidism, it's either Hashimoto's thyroiditis, you treat them the same anyway. Whatever the cause is, you treat it the same. Hyperthyroidism, though, you treat it totally different if it's Graves' disease and if it's subacute thyroiditis, right? Everybody understand that? See, because because the difference in scan allows you to differentiate between these three diseases and figure it out. So for Graves' disease, I treat it one way. Subacute thyroiditis, totally different way. Right? Everybody okay with that? Okay. All right. You guys want to stop there and we'll take a 10-minute break? And we'll come back and talk about more about this stuff. This is interesting stuff. A lot of good questions. All right. I'll see you guys in 10 minutes. All right, everybody. Let's do a 2-minute review. When the TSH in an undiagnosed patient with thyroid disease, normal TSH means that the patient is euthyroid at all times. All right, so we got to remember that. Okay, give me 2 scenarios where we use thyroglobulin in the testing. Cancer and factitious. See, we don't have a lot of tests in thyroid disease. We have TSH and T4 and T3, and, maybe a couple more. Not a lot. Okay, radioactive iodine uptake. When do we do a radioactive iodine uptake? In hyperthyroidism when we're not sure of the cause. Kathleen said it nicely. Unclear hyperthyroidism. Okay? If you know it's Graves, then you don't have to do it, right? If you're sure it's Graves. The problem is the patient comes in with hyperthyroidism sometimes, and we don't know what the cause is. Okay? Everybody understand that? For example, give me an example of a patient presenting with clinical hyperthyroidism but has a radioactive iodine uptake scan that is low. Give me an example of that. Subacute thyroiditis, right? Decurvence. And we said Hashimoto's could do it, but that's rare. The one that really does it is subacute. Or factitious. Somebody said factitious. Right? So those three are right. It's just with Hashimoto's, they usually don't come to us. Okay? Everybody okay with that? All right, if you guys know that, you already know a couple questions on the USMLE. They focus on that a lot. They don't want you to think hyperthyroidism equals Graves all the time. Okay? All right, so let's talk about that. So the hyperthyroidism, the etiology, right? Okay, could be Graves, that's the most common, but you should think about toxic multinodular goiter. That's the one I just showed you before with the 2 hot spots there. We could have subacute thyroiditis. We said, what's another name for subacute thyroiditis? Decurvence. And then we could have extrathyroid source. The typical one is factitious. Stroma ovarian can occur too, but that's rare. It's typically factitious thyroiditis. Okay? Very good. So look at this. When we have Graves' disease, the patient typically has hyperthyroidism, a diffuse goiter, and exophthalmos. All right, so I'm going to tell you something else now, and it's going to be 100% for the USMLE. If a patient has exophthalmos, the patient only can have Graves' disease. No other disease for us. If the patient, they show you a picture with the proptosis and the exophthalmos, the only disease it can occur in is Graves' disease. These patients have exophthalmos that sometimes also worsens with treatment. So they ask the question, what is the only symptom and sign of Graves' disease that can worsen with treatment? It can worsen. Doesn't always worsen with treatment, but it can. So you have to watch the patient closely. The answer is exophthalmos. Yes, especially with the radioactive iodine treatment, right? That's when people say, like, maybe because you're killing off the cells and you get all these things that cause the proptosis to come out, right? So be careful about the exophthalmos. You diagnose Graves' disease just by seeing it. There's nothing else, or you don't have to do, you have to check a TSH and a free T4, but other than that, you're done. And be careful when you're following up a patient with Graves' disease. Always check at the exophthalmos, okay? Because it may get worse while you're treating the patient. This disease occurs in women in about their 4th decade. It's an autoimmune disease, so you always have autoantibodies. These autoantibodies are called TSI, thyroid stimulating immunoglobulins. Thyroid stimulating immunoglobulins. So they basically act like long-acting TSH. That's what they are. They are They have other autoantibodies against the extraocular muscle. So that's why, they say sometimes that the exophthalmos gets worse, maybe because some of this stuff, gets out into the periphery. Okay? And then it's associated with other diseases, other autoimmune diseases, pernicious anemia, myasthenia gravis, and diabetes. All these autoimmune diseases are interconnected. The typical presentation of hyperthyroidism is Graves' disease. They present with nervous system symptoms. They have cardiovascular. Now, somebody was asking about high output heart failure. This is the one that has high output, typically heart failure. High output heart failure occurs with hyperthyroidism and anemia. And older patients, they tend to have more the myopathy, the proximal myopathy. They have inability to sleep, they have tremors, they have diarrhea, sweating, heat intolerance. It could be severe, especially in the summertime. So I had a patient like that, had a very hard time, with the summertime. They have weight loss. They have dyspnea, palpitations, angina. And we said high output heart failure. They develop sometimes palmar erythema, right? Just like sometimes cirrhotic patients, and they have pretibial myxedema. Pretibial myxedema, even though it is characteristic about Graves' disease, it's not pathognomonic. It could sometimes be seen in other thyroid diseases. It is rare, but it may be seen in other thyroid diseases. If we see it on the USMLE and they show this non-pitting edema below the knee, okay, it's Graves' disease, but it's not pathognomonic like the proptosis. Okay, so pretibial myxedema, they sometimes ask about it. So Kate asked if this was, specific. It's relatively specific, but it's not pathognomonic. So it's interesting because they put the word, you hear myxedema and you think it's hypothyroidism, but it's more related to hyperthyroidism, to Graves' disease, right? Pretibial myxedema, non-pitting edema below the knee. All right, so what do we do with Graves' disease? So we do the thyroid studies, right? The TSH is very suppressed. The free T4 and the free T3 is very elevated. Okay, if you have the proptosis, the exophthalmos, you don't need anything more. You're done. Okay? If it's not clear, so maybe the patient doesn't have proptosis, not everybody does. You're questioning maybe this guy's got some other diagnosis, you want to confirm the diagnosis, right? Then you do the radioactive iodine uptake scan. Usually not needed, but when there's a question, go ahead and do it. It shows a diffuse increased uptake, like the first radioactive iodine scan that I showed you, which shows a homogeneous, right, uptake. TSI, thyroid stimulating immunoglobulins, are also positive. You could also get those. The endocrinologists love them, because they, like to check stuff like that, but it ain't going to change the management of your patient. Okay, so it's nice to know this stuff, but it won't change what you do for your patient. All right, so now we diagnose it. So the treatment and management of a Graves patient is twofold, right? One, it's the immediate. You got to treat it right now, right? That's with propranolol and antithyroid drugs. So you give beta blockers. You could give other than propranolol too, other beta blockers. But you give beta blockers. The one that has been studied the most in Graves' disease is probably propranolol. You could give other ones too. It's to control the adrenergic symptoms. And then at the same time, we give antithyroid drugs, PTU or methimazole. So in the everyday patient with Graves' disease, you could give either one, whatever you like, whatever's cheaper. If the patient is pregnant, then you got to give only PTU. So there's some literature, right? There's some literature to say like you could give PTU later, and you could try methimazole, early. Please, if the patient is pregnant, just give them PTU. It's the only one that is considered safe. It's considered safe. It's still unclear if it's safe because it does cross the placenta. Do you have to give propanolol in every case? I mean, listen, you might have, if it's a very mild case, you don't have to, but these patients can't sleep at night. That's what they come to you with the, adrenergic symptoms, right? That's what they come to you with the tremulous and stuff like that. So you know, 99% of them will get beta blockers, and you have to give the antithyroid drugs. So this first part, this immediate, yeah, but it does act on the conversion of T4 to T3, but that's minimal. The effect, Jose, is minimal. That's important, when you have thyroid storm, so you're trying to buy every inch you can, But in the real world, look, yes, it does block T4 to T3, but it's PTU and methimazole that will do that, right? So you give a combination of both. Everybody okay with that? So in this immediate first phase, what you're trying to do is cool down the thyroid. Everybody understand that? Cool down the thyroid. What does that mean? I'm trying to suppress the thyroid. I'm trying to get the patient ready for definitive treatment. Definitive treatment is when the patient is euthyroid clinically and biochemically. And now you do long-term treatment. I mean, basically permanent treatment. And that's the answer to that is radioactive iodine. Okay, so listen, a lot of us have practiced abroad. They don't do that. A lot of people, in a lot of other countries, they don't do radioactive iodine ablation, right? So, but in this country, that's the mode of treatment. Okay? Remember, I said in the pregnant patient, you got to give her propanolol and PTU. I didn't say it was safe. I said it was safer. Both of those cross the placenta. So there's a lot of people that say, look, this has crossed the placenta. I'm worried, and you should be worried. Okay? But those are safer than anything else. Okay? Everybody okay with that? Kathleen, that's a good thought because it does, all of these cross the placenta, and they tell you they've been associated with issues on fetuses, small for dates and all that business. Right? All right, so now they may ask us, now remember, when we do radioactive iodine ablation, we give them, a lot of iodine, it's radioactive, we kill off the cells. So what do we do to this patient eventually? Make them hypo, right? Because people in this country say hypo is much less dangerous than hyper. And now Dinesh says we give them replacement forever. So, some of the patients have a problem. They say, Doc, what are you doing? You're going to make me hyper from hyper to hypo? Yeah, it's much safer to be hypo than hyper. Hyper is dangerous. If they stop their medication, they go into thyroid storm, 60% mortality. Okay? So now the question they ask us sometimes is, in this country, when do we consider thyroidectomy? All right, so here's the answer. So pregnant patient, well, not never, but not, very few, in very few instances. No, we're talking about management of Graves' disease, not cancer here. Okay? Now, hold on. We're talking about management of Graves' disease. When in Graves' disease do you do thyroidectomy? So the answer is if you have pregnancy, second trimester, because you don't want to escalate what Kathleen was talking about, propanolol and antithyroid drugs. So you give them a couple months of that, cool down the thyroid, second trimester, take it to surgery. That's one possibility. Second possibility is if you have a very young person with Graves' disease, a child. That's rare, but we don't like to give children, radioactivity and stuff like that. And number three is if you have Graves' disease that is causing pressure, right? It's big enough to cause pressure, right? That's when you do surgery. Okay? Everybody okay with that? Can you guys remember the three scenarios? Pregnancy, children, pressure, right? When you get pressure phenomena. Okay? There you go. Done. Everybody else gets radioactive iodine ablation. And you're done. All right? So people in this country believe it's better to have hypo. I'm not saying it's right. I'm telling you what you're going to see. Right? Those are the recommendations, so we got to stick with those. Everybody okay with that? All right. So I want to tell you a little bit about one other thing, two more things. Toxic multinodular goiter. All right? Remember I showed you that where you have the thyroid like this, right? And you have, an area here that's acting up and an area here. So this is a non-autoimmune disease. These patients actually before have like a simple goiter. And, it's not acting up and then all of a sudden it starts to act up. Okay? When this is a disease of older individuals. We said Graves, young. Toxic nodular goiter, older patients. Right? So when I feel the Graves' disease patient, thyroid, it's diffusely enlarged, right? When I feel the toxic nodular goiter, what do I feel? Lumpy bumpy, right? I feel bumps, the nodules, right? Everybody okay with that? This guy's got a history of a simple nodule in the past and all of a sudden starts to act up. Nobody knows why. So I had a guy one time says like, my old doctor, he told me that it was okay. I don't know. Was he telling me the truth? And he was telling him the truth. Yeah, this was a non-toxic nodular goiter for a long time. And then it becomes toxic all of a sudden. Something triggers that. Nobody knows why. The interesting thing is, this is a disease of elderly, right? And they present typically with arrhythmias, cardiovascular complications. Okay, be careful about atrial fibrillation, AFib, in an older individual. Always work up for hyperthyroidism. Okay, everybody okay with that? Always work up. All right, very good. They don't have ophthalmopathy, and we treat them the same way as Graves' disease. So listen, they're going to ask Graves' disease or this, and they may ask both, because they're very, very common diseases. They love Graves, they love toxic nodular goiter, and they love subacute thyroiditis. Those three we have to know well. Okay? Everybody okay with that? We treat it just like Graves' disease. Straightforward. Older patient, lumpy, bumpy thyroid, cardiovascular complications, AFib. Okay, just a few words, thyroid storm. So what happens when you don't take your medication with Graves' disease? Well, you can get this thing called thyroid storm. Thyroid storm. So this is the one that has 60% mortality. Extreme thyrotoxicosis. Usually with surgery, with trauma, with stress, who knows? These patients present with delirium, coma, hypotension, heart failure, high fever. The fever is sometimes in excess of 104, 104 degrees. Okay? 104 degrees. Very high. That's when you think about thyroid storm, when you see very high fevers. Okay, so I told you these patients need to go to the ICU. It's considered a endocrine emergency. Everybody gets revved up with this disease. This is not a joke. Okay, what do we treat this patient? We treat them just like we treat patients with Graves' disease. We give them antithyroid agents. Now we give PTU. Okay, now you guys remember why we give PTU here? Because PTU blocks the conversion of T4 to T3. So you want every inch you could get. Okay? And then beta blockers, now you give propranolol. Right? Because now that also, there's a possibility blocks the peripheral conversion. So you're using everything you can. Okay? So anybody know why these patients develop hypotension? Stress. Maybe. Maybe they're really stressed. Well, if we give them propanolol, yeah. From the heart failure. That's right, Maura. From the heart failure. If you get severe heart failure, what happens? You develop hypotension. That's right. And that's what it is from the high output heart failure. Eventually, the heart gives away. Right? So, we treat this patient just like Graves' disease, but we use PTU and we use propanolol because those are specific drugs that may help us in this case. We also do some other stuff. We give them IV fluids and cooling blankets. Some people, this is kind of plus or minus, give dexamethasone with this. This is adjunct treatment because they think maybe this patient also has cortisol problems because there's some studies that showed that if you have severe forms of hyper and hypothyroidism, your cortisol is not working well or it gets eaten up too fast. So they give dexamethasone. These are adjunct treatments. Adjunct treatments, what's that? Like kind of like additional treatments. It's if you give it, it's nice. If you don't give it, you probably won't. It's not going to kill the patient, right? So don't get hooked up on the dexamethasone here, okay? But you have to remember this right here. So one of the cornerstones treatment, this is very important. In a treatment of thyroid storm, we give iodine. Iodine or iodide, either one. So there was this guy in California about 40 years ago, which showed in various experiments, and not in people, right? In animals, that if you give low doses of iodine, kind of like normal doses every day, what does your thyroid cells do? They take up the iodine and they make more T4 and T3, right? Because that's what the thyroid cells do in the first place, right? Good. So this guy then gave him a bolus, right? Gave him a bolus of iodide. And you know what happened? Well, Richard probably knows. It downregulated the thyroid cell. It stopped them from making more thyroid hormones. They got confused. They got so much iodide, they stopped making any T4 and T3. They were overwhelmed. They were downregulated, right? Everybody understand that? So why do I give iodine? Because people say, like, you're going to give iodine? Are you going to try to kill this patient? It's downregulation. Okay? I give them a bolus of iodine. Everybody remember that? Why? I want to suppress the production of T4 and T3. So if they ask thyroid storm, they're going to ask this. In step one, they've asked this a million times. Why do we give iodide, in thyroid disease? Because you downregulate. Okay? So I treat it just like Graves, plus the iodide, plus some adjunct stuff like corticosteroids, IV fluids, and cooling blankets. Okay? Thyroid storm is a very severe condition. You don't want patients to get this. This is why you treat them well before, so they don't get to this point. Okay, so I want to talk a little bit about hypothyroidism, the etiology. Well, hypothyroidism, the primary hypothyroidism, is 95% of the cases above the thyroid, secondary, and tertiary from the hypothalamus are very rare, right? Very rare. In this country, chronic thyroiditis, Hashimoto's, is number one. So if they ask as a disease, what is the most common cause of hypothyroidism? The answer is Hashimoto's thyroiditis. If they give you a patient who has hypothyroidism, even if they don't tell you the cause, you are to assume that the patient probably has Hashimoto's thyroiditis. Also, in this country, it is very common to see to see hypothyroidism after post-ablative radioactive iodine treatment, right? Because why? Because that's the way we treat Graves' disease. So those two are the most common causes of hypothyroidism in this country. And then there's some other stuff like drugs, lithium, amiodarone, and stuff like that. Look at this. Heritable biosynthetic defects. So I put this in here for a reason. People are telling me, some students showed me about 6 months ago, questions on adult patients with hypothyroidism. And everybody was stumped. And, well, could this be heritable biosynthetic defects? Adults don't get hypothyroidism all of a sudden because of biosynthetic defects. That's in childhood. You should have seen something. This guy is 40 years old now. They didn't come up with defects all of a sudden. Iodide deficiency. It's unheard of in this country. Everybody understand that? You and I and other people have seen this in other parts of the world. It is not seen in the United States, not from people living in the United States. Okay, so you guys are going to think Hashimoto's, or it's iatrogenic, or it's some medication. Everybody okay with that? If they don't tell you this guy had a surgery a radioactive iodine ablation for Graves, he's got Hashimoto's until proven otherwise. Okay, very good. And then we got to know a little bit about what hypothyroidism presents with. They like to talk to us about a presentation. So of course, because remember, if you're missing T4 and T3, you're like in a hypometabolic kind of condition. So these patients develop constipation, they have cold intolerance, they may develop carpal tunnel syndrome bilaterally. You guys remember we talked about the other disease that has bilateral carpal tunnel syndrome? What's the other one? Acromegaly, very good. They have pseudodementia. What's pseudodementia? So they have like a Alzheimer's-like syndrome. They got forgetfulness and stuff like that. They have dry hair, skin, hoarse voice. Be careful about the slow, deep tendon reflexes, right? So if you hit the knee, right, it goes up normally and then on the way down, right? It's delayed, right? Tap it, right? It goes up normally, on the way down, right? It goes slow. Okay, so the deep tendon reflexes are delayed on the relaxation phase. That's the importance of knowing this, the relaxation phase. Okay, relaxation phase. Not on the way up. Okay? All right, and then we need to know that it affects the cholesterol. They asked a question about what metabolic diseases, endocrine diseases do you need to think about when you have elevated cholesterol? So the answer is hypothyroidism. They give you an older patient, right, with normal cholesterol before all of a sudden his cholesterol goes up. You have to think about hypothyroidism, right? Everybody okay with that? This is important because the cholesterol here, they asked about treatment. Anybody know the treatment of hyperlipidemia in hypothyroidism? What's the treatment? Good, beautiful. Dinesh, so be careful. So that's what 60% of the students asked. They picked statins and fibrates. That's wrong. What's the answer? What's the answer? They're both wrong. Treat the hypothyroidism. That's it. The answer was levothyroxine. Okay? Levothyroxine. That's a great question. All right. So anybody know? No, that's okay. Listen, we want to get as many questions wrong as we want here, right? We want to answer everything wrong here so we remember. Okay. Who knows? Why do people get Oh, it's you guys are answering good questions. Why do people with hypothyroidism get carpal tunnel syndrome? Edema. That's right. Non-dependent edema. Right. That's the myxedema stuff. Right. That occurs in the extremity. So you know where the medial nerve goes through? Remember the medial nerve? Thumb. Right. First three fingers. Right. It goes through a very tight area. Right. Around your wrist. And if you have any edema there, like who else? They call it the snuff box. That's right. Who else gets edema there? Very common. Very common. What's a common scenario where people get it? Pregnancy? There you go. Right? They get edema there and they get bilateral carpal tunnel syndrome. Okay? Everybody okay with that? Renal failure. Well, renal failure, they get, not so much it's the edema. Does anybody know why they get bilateral? Dan, that's a great question. So, why do people get bilateral carpal tunnel syndrome with renal failure? It's third good. It's amyloid. All right, you guys are great. It's amyloid deposition. So when I see bilateral carpal tunnel syndrome, I think of three things: acromegaly, hypothyroidism, and amyloid, which occurs sometimes with renal failure. Okay, you guys okay with that? All right, very good. Let's talk a little bit about more. All right, so when the patient says, "How long are you going to treat me, doctor, for hypothyroidism?" What are you going to say? Lifelong, sir. This is forever, right? This is forever. All right. Make sure that the patient you give enough T4. In this country, we give back T4. T4. We try to simulate what the thyroid does. That's why I was telling you secretes primarily T4. That's what we give back. How much T4? Enough for the patient to become clinically and biochemically euthyroid, right? Make sure when you're checking thyroid levels, right, and you're equilibrating T4, TSH has a lag time. See, TSH is a great diagnostic test, but it has a lag time, 6 to 8 weeks. All right, so don't expect it to go back to normal right away. All right, so if somebody says, look, they come back in 3 weeks and they say, look, I feel great, and the free T4 is normal, right, but the TSH is still elevated, wait another 3-4 weeks before you do anything. It takes 6 to 8 weeks, right, to equilibrate. Okay, everybody understand that? So I said, let's say you have somebody, a 32-year-old woman, right, with hypothyroidism, comes back 3 weeks later after you gave her Synthroid, right, levothyroxine, and you've given her 100 micrograms of levothyroxine, right, and her free T4 is normal. And her TSH is still a little bit elevated, right? So free T4 normal. Let me make sure. This is normal, all right? Normal. TSH is still elevated. So they expect you to know that, look, wait a little bit more before you do any more adjustments. It takes the TSH 6 to 8 weeks to equilibrate. Okay? Also, please be careful if you suspect secondary hypothyroidism. Be careful because this patient is probably not only missing TSH, they may be missing ACTH. So you got to give hydrocortisone too, or check for hydrocortisone. Okay? So remember, if you have secondary, it means the pituitary is problematic. All right? If the pituitary is problematic, you usually are not missing a single thyroid, a single hormone. You're missing many hormones. So you're worried about having subclinical adrenal insufficiency at the same time. Okay? Always check the cortisone, and if in the real world you give hydrocortisone and levothyroxine until you get the test back. Okay? Everybody okay with that? Okay. All right. So last thing here, and we'll do some questions, and then we'll take a break. Okay. Myxedema coma. So what's myxedema coma? It's like thyroid storm, right? It's the worst thing that can happen to you with hypothyroidism. It's with long-standing disease. These patients develop stupor. Look now, hypothermia, right? It's typically precipitated by infection, cold exposure. The 3, 4 cases I've seen, these people, for one reason or another, have been exposed to cold. One woman fell asleep on the park at night, and had hypothyroidism and developed myxedema coma. So there's some exposure to cold or infection. How do we treat it? We treat it with very high doses of T4 and T3 at the same time. All right, so now you guys are going to tell me, why do I give T3? I don't usually give T3 in hypothyroidism. Why do I give T3 here? More potent. That's it. So in the everyday hypothyroid patient, I don't care. Just give them T4, let it convert. But now I want to give T3 ready, quick to respond, right? It's acute, it's potent, right? I give them warming blankets, right? Because you give both of them, right? Because you want them to convert normally when they get to that point. Okay, well, you give warming blanket, you give IV fluids, right? And look at this. They give corticosteroids, right? So this is, again, adjunct treatment, right? Just like we did before with thyroid storm. It's adjunct treatment. People think that if you have very severe forms of thyroid disease, you need corticosteroids. They just don't work as well when you have bad thyroid disease. So, but this is not, this is adjunct treatment. This is adjunct treatment. These patients, right, they may need ventilation, right, and because they're in a coma, so you may need to protect the airways and intubate them and so forth. But the primary treatment is right here, a combination of T4 and T3, right, both at the same time, very high doses. Okay? All right, very good. Okay, I want to finish up talking about thyroiditis. So there's 2 types of thyroiditis. One where you have an acute event, very inflammatory, and it goes away. So it comes, it hits the patient, it causes intense inflammation, goes away. This is called giant cell decurvens thyroiditis. It's of viral origin. The virus causes inflammation, the cells spill the thyroid hormones. So how does the patient present? If you spill the thyroid hormones in the periphery, this patient presents with hyperthyroidism. If you touch the patient's thyroid, the patient jumps back, right? They have thyroid pain. Sometimes they have jaw pain. So I had seen a patient once that was being evaluated for heart attack, right? Because they thought he had a heart attack with the jaw pain and stuff like that. They may ask us about abnormal testing. And the answer is that they always have 100% of the time, 100% of the time, their erythrocyte sedimentation rate is always elevated. That's 100% of the time, right? There's an initial elevation of T4 and T3, right? And then they go back to normal over time, right? Eventually, this disease subsides. It goes away. They become euthyroid, right? So it always goes away. See, this is the reason why they ask this every year about subacute thyroiditis, because if you make a mistake and you think it's Graves' disease, you treat it wrong. Look at here. I don't have to do anything to this patient. I treat the symptoms, the pain, aspirin, right, and prednisone, right? So if your T4 and T3 are up, your free T4 and your free T3 are up, what happens to your TSH? Goes down, right? That's a given. See, this looks just like any other form of primary hyperthyroidism. Elevated free T4, elevated free T3, low TSH. So, but what makes you think about subacute thyroiditis? You touch it, it's painful, right? And then look at this. Look at this. The radioactive iodine uptake. Remember that? When I'm unsure about the cause of hyperthyroidism, that's when I do the radioactive iodine uptake, right? It's decreased. Everybody okay with that? Make your diagnosis, right? If you want to get a SED rate, just to be sure, fine. But, you pretty much confirm the diagnosis with the radioactive iodine uptake. Give them some aspirin, give them some NSAIDs, it'll go away. If they have a lot of palpitations, they can't sleep at night, you may give them a little bit of beta blockers. That's fine. Do not give them PTU or methimazole. Do not. See, look at the natural history of this disease here. So follow, this is the free T4. It's called the free thyroxine index. Follow this. So see that? It's above normal. It dips to below normal, and then it goes back into normal. See that? That's the natural history of the disease. So if you follow it out 3 months, it goes back to normal. Comes up high, right? Because the inflammation and the spilling of the hormones, it goes down after about a couple of weeks, right? And then it goes back to normal, right? Treat the patient symptomatically. Everybody okay with that? That's the natural history of this disease. So they may ask you about this. This is a good question for you all. Okay, just a few words about Hashimoto's, and then we'll take a break. So you see, Hashimoto's is different. You don't have intense inflammation that comes and goes. You got chronic inflammation and lymphocytic. This is a typo. Lymphocytic infiltration, right? Lymphocytic infiltration, right? So what do you get with chronic inflammation? Eventually, fibrosis and scarring and hypothyroidism. So Decurvens presents with hyper, and then it goes away. Hashimoto's presents with hypo and is permanent. This is the most common cause of hypothyroidism, right? So this is an autoimmune disease. That's why we have antithyroglobulin antibodies, antimicrosomal antibodies, TSIs, and all that business. That's why it's associated with autoimmune diseases. When you touch the thyroid, it feels rubbery because of the fiber tissue. Not always symmetrical, so you may get more scar tissue on one side than the other. Don't be fooled. Okay? The patient typically presents with hypothyroidism. Treat as any other form of hypothyroidism by giving them forms of T4, levothyroxine. Okay? Everybody okay with that? So how does subacute present? Pain. And why do they come to you? It's painful. What else? With hyper. Okay. And what's the natural history of the disease? The natural history of the disease. It goes away. Very good. Okay? And what's the test that is always abnormal with Decurvens thyroiditis? The SED rate. Okay. Hashimoto's thyroiditis presents with hypothyroidism. There you go. And what's the natural history of Hashimoto's? Permanent, and sometimes associated with other autoimmune diseases forever. Okay? Everybody okay with that? All right, very good. All right, we got 2 more minutes. All right, a 27-year-old woman comes to your office for throat pain for 1 week and palpitations. She has no prior history. She takes no medications. Her pulse is 142/92. His pulse is definitely elevated. Her oropharynx is normal. Thyroid is painful and diffusely enlarged. So what do you guys think? Subacute. All right. All right, let's see what they want. The TSH is low. The free T4 is elevated. The radioactive iodine is low. What would be the next appropriate test? See, so this is an inappropriate question, right? But you have to answer it to the best of your knowledge, right? They shouldn't be asking you for a test because they already know the diagnosis. You already know the diagnosis. There you go. But if they do ask for a test, it's the erythrocyte sedimentation rate. Okay? What would have been a better question is, what is the next appropriate step? What's the next appropriate step? Treatment, right? NSAIDs, aspirin. Good. There you guys got it. All right. Could we do one more case? And then we'll take a break? One more. Okay? A 32-year-old man, right, is admitted to the ICU with delirium and is treated for sepsis. Thyroid hormones drawn on the day of admission show very low free T3. The TSH is normal. There is concern about myxedema coma, okay, and is given a history of a thyroid nodule. What do you guys think? Oh, what do you guys think? Ooh, all right. So what did I tell you happens when the TSH is normal for our purpose? It's euthyroid. Remember, they're trying to trick you guys. First of all, is the thyroid nodule associated with myxedema coma? No. Yeah, they're throwing, red herrings at you. What did we always say when the TSH is normal? That was tricky. I know. Okay. It's okay. We get it wrong now, though, right? Good. So I think you guys got it. This patient's euthyroid. Anybody know what this is called? There's a special name when patients are very sick and they have sepsis and they have derangements of T4 and T3. Good. Kate said the sick euthyroid syndrome, not sick sinus, sick euthyroid, right? Sick sinus is this, right? It's in the heart, right? This is sick euthyroid syndrome, right? Everybody okay with that? Some people that are very sick, what happens? Their T4 and T3 goes down. People say it's probably because the body goes into a catabolic, phase, trying to preserve itself. Who knows? But T4 and T3 is low, but the TSH is normal. And when I said to you guys, when the TSH is normal, we don't have to worry about anything. The patient is euthyroid. Okay? All right. Why don't we take a 10-minute break and we'll come back and talk a little bit more about this and finish this up. Okay? All right. Very good. All right, everybody. Just a couple of things. Where do we see antibodies? What diseases of the thyroid do we see antibodies in? The autoimmune diseases, right? The typical ones are Hashimoto's and Graves', right? So we see a couple of different antibodies. One is called the anti-thyroid peroxidase, anti-TPO antibody. That's seen in about 90% of the cases with Hashimoto's thyroiditis, and maybe about, depending on what you read, anywhere from 60 to 75% of the patients with Graves' disease. Thyroid stimulating immunoglobulins, TSIs, are seen in almost all the cases with Graves' disease, like 95%. And then in a small percent of the patients sometimes with Hashimoto's. So both of these, have different types of antibodies. TPOs are most commonly associated with Hashimoto's. TSIs are more commonly associated with Graves' disease. Okay? All right, so you guys should be able to figure this out. A 57-year-old woman comes to your office with fatigue, palpitations for 1 month. She has a history of a goiter. She takes no medications. Her blood pressure is elevated. Her pulse is 97 and is irregular. There are 2 large nodules in the left thyroid lobe. There's no proptosis is noted. So what does she likely have? What does she likely have? Good. So this is called toxic multinodular goiter. Toxic multinodular goiter. Okay? Everybody okay with that? So we said Graves' disease, the young, right? Toxic nodular goiter, the older patients with hyperthyroidism, and they typically present with cardiac manifestations. Okay? Everybody okay with that? All right, very good. A 24-year-old medical student comes to your office for weight loss of 15 pounds over a month and palpitations. She takes no medication. She reports no constitutional symptoms. Her blood pressure is elevated. Her pulse is elevated. The thyroid is normal. No evidence of proptosis, and fine tremor is noted. The TSH is low. The free T4 is elevated. Perswag said that she's studying for step 2, probably. The radioactive iodine uptake is low. What would be the next appropriate test in the evaluation of this patient? All right, so you guys said thyroglobulin, right? Thyroglobulin. Okay, so you guys said, remember, she said no medications. You don't believe her? Nicole, no, huh? She swears on her fiance that she's not taking anything. Okay, good. All right. So that's the answer. So we got to check a thyroglobulin. All right, so you're worried about factitious, right? All right, very good. So when do we use the thyroglobulin? For factitious and the follow-up of cancer. All right, 32-year-old woman. Right, so it should be low. Jose says, right? So what do you see here? Let's say they give you the thyroglobulin. Remember, in this case, free T4 is elevated, but thyroglobulin is low, right? So remember, you're not making endogenous T4. It's exogenous, so your thyroglobulin is low. Okay? Very good. A 32-year-old woman comes to your office for weight loss, 12 pounds over 1 month, palpitations, and generalized weakness. She takes no medication. She reports no constitutional symptoms. Her blood pressure is okay. Her pulse is elevated. Her thyroid is diffusely enlarged. Proptosis and fine tremor are noted. All right, so what is the only thing she could have? All right, so they give you TSH is low, free T is elevated. The scan, the radioactive iodine uptake scan, is definitely elevated, right? Diffusely elevated. So they said, what is the next appropriate test in this case? So that's a bad question, but you got to answer it. All right, so the answer is they're asking for antibodies, TSIs, right? Now, is this a good question? No, because you made the diagnosis already. Why do you need TSIs? But that's what they're asking for. A more appropriate question would have been, what is the next appropriate step in management of this patient? But what would be the right answer? Good. So Jeremiah said propranolol, right? Propranolol and what else? And PTU or methimazole. Okay? Everybody, remember you got to give beta blockers and anti-thyroid medication. Okay? Everybody okay with that? All right, very good. Okay. So they may ask a question. They will likely ask a question about a thyroid nodule. All right, thyroid nodule. We worry about thyroid nodules that this is cancer, right? And the teaching, the classic teaching is that all non-functioning nodules are presumed to be due to cancer until proven otherwise. Right? So they're telling you, if the exam and the TSH are both normal, there you go, both normal, then you got to think that this is a non-functioning nodule, and it's presumed to be cancer until proven otherwise, which is I do a fine needle aspiration. That's it. What's the next step? A fine needle aspiration. So first you do a good exam, you check TSH, and then a fine needle aspiration. If the fine needle aspiration shows cancer, right, you send the patient to surgery. If it's benign, all right, so now you follow the patient, tell them to come back, see you in the office in anywhere from 3 months to 4 months, something like that, just to make sure everything is okay. Okay? Everybody okay with that? So what is the test of choice to evaluate thyroid nodules? A fine needle aspiration. Okay, now people do this fine needle aspiration under ultrasound guided. Okay, so don't get mixed up. It's not the ultrasound that you do to evaluate the thyroid nodule, is you do the fine needle aspiration under ultrasound guided. Okay? The people that have high suspicion, even higher, right? Right, so it's the same thing as a ultrasound guided biopsy, right? Same thing. So the people that have even higher suspicion of cancer are people that had radiation to the head and neck area, people that have thyroid nodules and lymphadenopathy. Yeah, that's a worrisome thing, right? Men, even women have more likely to have nodules. Men are more likely of a nodule being cancer. And then elderly individuals. Watch the radiation to the head and neck area. That is very high suspicion. That is cancer. They got like 10 years ago, they got radiation to the head and neck area because they had Hodgkin's lymphoma or, something like that, right? Those are high-risk patients. Okay? Do the exam, do the TSH, do the fine needle aspiration, figure out if this patient has cancer or not. Okay? How do you guide your biopsy? Under ultrasound. Okay? Everybody okay with that? Okay, very good. All right, so look at here now. A 32-year-old man comes to the evaluation of a neck mass. You find a 2.5 centimeter thyroid nodule on the left thyroid lobe. There is no lymphadenopathy. The vitals in the examination is otherwise normal with no evidence of thyrotoxicosis. What would be the next appropriate step? So they got to give you normal, right, examination, and they probably they mean a normal TSH, right? Okay, what's the next step? All right, so the next appropriate step we said is a fine needle aspiration. Not a radioactive iodine, right? A fine needle aspiration, okay? Everybody okay with that? So listen. So here's what you guys want her to do, right? So this guy's got a cold nodule, right? This is likely cancer. You see the cold nodule there? Doesn't pick up? All right. How do I know that this guy's got a cold nodule already? I don't have to do a radioactive iodine uptake scan. I don't have to give the patient radiation. How do I know that this guy already has a cold nodule? Because this guy has no, if it would have been hot, it would have secreted something. Normal tests, right? So see, there you go. No evidence of thyrotoxicosis. See, if you got hyperthyroidism, the chances of cancer there's zero. I mean, it's not zero, nothing's zero, but it's, 99%. Everybody understand that? That's why, if you go to Europe and other parts of the world, they start with the radioactive iodine uptake scan. There's no need for that. There's no need for that. Not in this case because you already know. Okay? Everybody okay with that? Go for the money, right? Go for the needle. All right? Everybody feel comfortable with that, right? So this is going to ask you, listen to this. What's the most common thyroid cancer? We're going to talk about that in just a second. Who knows what's the most common thyroid cancer? Papillary. Okay? Anybody know the survival of papillary cancer? 10-year survival. What's the 10-year survival? You're very close, Tamina, very close. 90%. That's it. Over 90%. So this is a very curable cancer. That's why they ask this question every year. They don't want you to miss that. Nodule, non-functioning, do fine needle aspiration. All right, so let's talk about the thyroid cancers. So the most common one is papillary. The survival is over 90%, 10-year survival. This is the one that's also associated with radiation to the head and neck area. So if you got exposed to radiation, if you were in Chernobyl or in other areas in the United States where you got exposed to radiation, that they get papillary cancer. Right? It's the one also that doesn't spread hematogenously, very rare. Doesn't give far off metastatic disease sites to other organs. Usually local, right? Local lymphadenopathy. It goes through the lymph nodes, very predictable, right? Makes up most of your thyroid cancer. So this you don't want to miss. Follicular is the second most common one, right? This is also very curable. So maybe it's not 90%, but it's sometimes 70 and 80%. Now this is very curable. This is the one that occurs in older people. This is the one that sometimes, if missed, may cause mets to faraway sites, bone, organs, and stuff like that, right? If they give you thyroid cancer with mets to the liver, the bone, and stuff like that, you're talking about follicular. And then we have medullary. Medullary is also important. Remember, this is now the parafollicular cells, the C cells, calcitonin cells, right? All that stuff. It's associated with multiple endocrine neoplasias. Be careful, some of these are associated with other tumors, so you got to work them up. We'll talk about that tomorrow, about multiple endocrine neoplasias. It's also associated with a familial thyroid cancer type that only has a medullary cancer. So they don't have to have multiple endocrine neoplasias. So the guy says, I got thyroid cancer, my brother has thyroid cancer, my father had thyroid cancer. Right? So familial solitary. If you hear thyroid cancer running in families, they're talking about medullary cancer. And then the other one is anaplastic. Now this one is rare, and that's good that it's rare because it's one of the worst cancers anybody could have. Very aggressive. Patients live to 5 years. The exact opposite of papillary, where papillary is so benign. Very aggressive. And it spreads locally. Doesn't metastasize. Spreads locally, invades local areas there. Typically trachea, blood vessels, and so forth. Luckily, this is rare. It occurs in older patients. So a bad cancer to have. The way we treat thyroid cancer typically is thyroidectomy. Okay, so they may ask two things. How do you manage this person? And what they're getting at is after you remove thyroid cancer, what you have to do is give a higher dose of thyroxine, levothyroxine, right? So you take out we do total thyroidectomy, you take it out, and now you have to replace T4. You give a higher dose than you would have given. So let's say this guy 50 micrograms, you give them a little bit higher than his normal dose, right? A little bit higher than his normal dose. So he would have probably gotten 175 or 200 micrograms. So the question is for all cancers. Well, listen, anaplastic and stuff like that, and lymphoma, no. But the two most common ones, right? The two most common ones, everybody pretty much agrees on that's probably the way to go. All right, so we do it in the papillary cancer and definitely follicular. Medullary is questionable. Anaplastic, they're probably not going to live. They're very aggressive cancer. But generally, if you do it, you probably, are protecting the patient. So anybody know why they do the suppression of TSH? What the concept is behind that? Why would you give a little bit higher than normal dose of thyroid hormones? That's a good question. Right, so you're trying to, right, so you want to suppress the TSH so it doesn't what? It doesn't stimulate cancer cells, right? That's what you're trying to do. Inhibit the feedback, that's right. Hopefully it's not going to reactivate. So anybody know for how long you do it? 10 years. 10 years. You do it for 10 years. If the cancer hasn't come back in 10 years, then you're okay to go back and, treat the patient regular. Okay? And then the second question that you guys know already. How do I follow thyroid cancer? How do I follow it? Thyroglobulin. That was the answer. Okay? Not the TSH, thyroglobulin. right? I want to see if thyroid cancer cells come back, they would produce thyroglobulin. Okay? All right. So look at here. A 34-year-old woman with a history of papillary thyroid cancer removed 9 years ago. She takes Synthroid, that's a form of T4, 250 micrograms per day. Her exam is unremarkable, but her TSH is low and her free T4 is a little bit on the high side. What would be the appropriate adjustment in her thyroid replacement treatment? What do you guys think about that? All right, so the answer is leave it alone, right? Nothing. That's the answer. Don't do anything. How how come? Well, what did I just finish saying? What did we just talk about? Didn't we say you're going to give a little bit higher dose and suppress the TSH? And everybody was saying yes, 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 yes. That's what we just said. Everybody okay with this? We want to give the higher dose. They expect you to give it, right? For how long? 10 years. 10 years. So next year, if she's without cancer, hopefully, she's going to be fine. What are you going to do next year now? Now you're going to do what? You're going to go back to normal now, right? You're going to taper down, okay? Well, right, check the thyroglobulin levels, etc., right? But in terms of adjustment of thyroid replacement, right? Everybody okay with that? Be careful. They've asked this multiple times. The reason they ask multiple times is because this person, goes to the endocrinologist and the endocrinologist tells her to do this, and then they go to the primary care physician who are not familiar with management of thyroid cancer. And what do? They see this and go, oh my God, let me lower your dose. Take it down to 150, 200 right away, right? They don't want to do that. This is intentional, right? Everybody okay with that? So at 10 years, if the cancer hasn't come back, then you could go back and give her normal doses of Synthroid, T4. Means that, these two both should be normal. Okay? Everybody okay with that? All right, very good. Okay, wonderful. All right. Yes, so Anna Maria asked a very good question. Okay, so when do we use radioactive iodine in cancer? So I didn't talk about it. So radioactive iodine is adjunct treatment to thyroid cancer. What's the primary treatment of thyroid cancer? The primary treatment? Surgery, right? So listen, is it in every case? No. I mean, if you have metastatic disease, no. All right, but 90+% of the cases, it's surgery. If you have a big thyroid mass, right? If you have a big thyroid cancer, a local cancer, they will radiate it at the same time just to make sure they got all of it. If you have thyroid cancer with lymphadenopathy, then you do adjunct XRT. So the question is, when do we do radiotherapy in thyroid cancer? The answer is, it's always adjunct to surgery. when you have a big cancer, or when you have local lymphadenopathy. Okay? Everybody okay with that? Okay, very good. All right, let's finish up talking about calcium disorders. All right, remember we said thyroid hormones are latched on to albumins. Well, so is calcium. 40–60% of calcium, it is total calcium, and it's bound to albumin, right? 40–60% bound to albumin. So not only thyroid hormones get affected by albumin, but so does calcium, right? So they ask, what is the first thing you do when you have hypocalcemia? What's the first thing we do when we have hypocalcemia? We look at the albumin and we correct for the albumin. We check the albumin, right? Everybody okay with that? You've got to remember that. Anybody know the adjustment? What's the adjustment? Good. Zia says 0.8. That's right. So for every drop in albumin by 1 point, right, from normal. So normal albumin is 4. A drop by 1 point, your calcium drops by 0.8. Right? Everybody could see that? Every point of drop of albumin by 1 point drops your calcium by 0.8. So that's why people with low albumin have also hypocalcemia. You measure total calcium. Unless you get only ionized calcium, right? This comes back as total calcium. The calcium that you get from the comprehensive panel, it's total calcium, 40–60% bound to albumin. Okay? So once we correct for the albumin, then we go further and we look at the calcium. If a patient has hypercalcemia, they present with neurologic effects, lethargy, confusion. They present with GI, abdominal pain, constipation. Remember moans, groans, and all that stuff? They present with stones. They present with polyuria, polydipsia. Now look at this. I'm going to ask you guys, where's the polyuria, polydipsia from? I remember DI, wonderful. Nephrogenic diabetes insipidus, wonderful. Because what did we say were the causes of nephrogenic diabetes insipidus? Hypercalcemia, sickle cell disease, demyclocycline, lithium. Beautiful. Okay? And the hypercalcemia also causes an effect on the cardiovascular system. A short QT interval may be a manifestation of hypercalcemia. Then hypercalcemia, we need to know the etiology. We need to know that hypercalcemia is most commonly caused by hyperparathyroidism. So if they said, if you take 1,000 people with hypercalcemia, what is the most common cause? The answer is primary hyperparathyroidism. What's primary hyperparathyroidism? Primary hyperparathyroidism. Good. So you got an adenoma secreting PTH, right? Activating the osteoclasts, etc., etc. Right? So remember, what's the primary hormone that affects calcium? PTH. We'll talk about that even more tomorrow. PTH activates the osteoclast to release calcium. What does PTH do to phosphate? Decreases it. You trash it. You get rid of phosphate. Okay? Which hormone in the body, deposits calcium? Calcitonin. What's the other deposits calcium, right? Vitamin D is the other player. Where do you get vitamin D from? The sun and the food. And what do you need to activate it? You need two organs to activate it. The liver and the kidney, you got to hydroxylase it, right? 125. Skin, diet, kidney, liver, right? Okay, very good. Okay, wonderful. So hyperparathyroidism is the most common cause. You secrete parathyroid hormone, and this parathyroid hormone, right, activates the osteoclast, it releases calcium into the serum, and you do away with phosphate. Doing away with phosphate is just another way to be able for the body to mobilize calcium. It's a very important way to do that. The second possibility is malignancy. So malignancy, calcemia. So they did this study decades ago in hospitalized patients where they looked at people with hypercalcemia that were brought into the hospital because of severe hypercalcemia. Most of them had malignancy. So even though hyperparathyroidism is the most common cause all around, when you take patients with severe hypercalcemia, these patients tend to have cancer most of the time. The more severe the hypercalcemia, the more likely to have cancer. There's two ways that you could get hypercalcemia related with malignancy. It's from bone mets, that's the multiple myeloma one, breast cancer one, etc., or look at this, PTH-like substance or PTH-related peptide. They like to ask that one. That's from lung cancer, squamous cell lung cancer. Squamous. There you go. Squamous cell, right? Cancer. So they may ask you that. All right, so this PTH-like substance, yes, so Claire says other ones. Yes, you could get other ones. So listen, it's not only squamous cell lung cancer of the lung, right? It's squamous cell cancer of the esophagus, head and neck. And then you could get other paraneoplastic syndromes like renal cell cancer and stuff like that, right? And you could even get small cell cancer secreting PTH-like peptide. But the one that typically does it is squamous cell cancer, typically in the lung. So this PTH-like peptide doesn't get picked up by the parathyroid assay that we use to measure PTH in the body. So this one is a very specific, it's a very specific test that picks up only the parathyroid hormone that you secrete from the parathyroid glands. So in PTH-like substance or PTH-like peptide, your PTH is low. You have to ask specifically for them to do PTH-like peptide. Everybody understand that? Be careful. They ask, what is PTH in these patients? The answer is, it's low. Right? You got to ask for PTH-like peptide. Okay, we know sarcoid. What's the story with sarcoid? How does sarcoid do it? How does sarcoidosis cause hypercalcemia? Granulomas secrete, good, the macrophages, they activate vitamin D. So you got a lot of vitamin D, especially when people stay in the sun. So they get this type of hypercalcemia in the summer when they go out into the sun. You could get also a benign form of hypercalcemia with prolonged immobilization. You could get it sometimes with hyperthyroidism because hyperthyroidism activates bone and releases calcium. And then there's this disease called familial hypocalciuric hypercalcemia. So this is also a benign disease. Now this, I got to stress, because they might ask us about familial hypocalciuric hypercalcemia. So it's a benign disease, right? It runs in families. The problem is these patients, their kidney, look at this, doesn't get rid of enough calcium. You see that? So what do? They develop hypercalcemia. Okay, so there's something, it's like your kidney gets rid of, when the levels of calcium go beyond a point, it gets rid of it. These people's kidneys, they hold on to more calcium. You could tell that because in the urine, the urine calcium is low. So why is that an important test? Because look at this. If your serum calcium is elevated, what does your kidney typically do? Flush it out. You get rid of it, right? If you've got high calcium in the body, you get rid of it. You remove it. What's the only exception to that rule? The only exception for our purpose, for the USMLE. If I measured urine calcium, everybody, this right here, there you go. Familial because that's where the problem is, right? All these guys here, their urine calcium is elevated. So yes, there's some exceptions and stuff like that, but you guys are going to know everything else, elevated urine calcium. Okay? All right? Everybody okay with that? All right. Do you guys remember the difference between HCTZ and loop diuretics? Loops get rid of calcium. Okay? What does HCTZ do? Thiazides don't. All right, keep that in mind. HCTZ keeps calcium, loops don't. Okay? Everybody okay with that? All right, let's finish up. Are you guys okay? We got about 10 minutes more. Is that all right? I want to finish this well, and then we all go home. Everybody feel good, right? All right, this is not too boring. Listen, it's okay if it's boring, but let's just learn it for the boards, right? Now, this is good stuff, yes, and this is good clinical stuff because you guys ask good questions. Okay, so look at this. Let's take a case. Let's take a case of hypercalcemia in the hospital. Tomorrow, I'll tell you more about managing hypercalcemia, but let's take a case in the hospital. What is the likely cause they came into the hospital causing the hypercalcemia? Let's see if you guys remember. What did I say? The worst, right? Oh, armpits and seizures. So, no, I'm not talking about symptoms. I'm talking about etiology. If somebody was brought into no, you're right about that, it's seizures, but it's, hold off. Let me go back. If somebody's brought into the hospital, it means they have severe hypercalcemia. What did I say? The more severe hypercalcemia, the more likely it's what? What did I say? The more likely it's, Z says malignancy. That's the answer. So if somebody's in the hospital getting treated for hypercalcemia, I will bet it's cancer 8 out of 10 times. Now, Sarah, what if I said, what is the most common cause of hypercalcemia throughout? That's a different question. right? Then it's primary hyperparathyroidism. Okay? So most of these are because of cancer. Okay? Most of them, not all of them. I mean, you could eat like 15 bottles of Tums and get it. Okay? All right. So how do I manage this patient? I give them normal saline. That's number one. All right. So when we give back fluids and medicine, we give normal saline. Okay. That's how we hydrate people. All right. What's number two? What's number two? All right. Number two. Hold off. Tinesh, you're right. Hold on. Number two is normal saline again. It's once number three. Normal saline again. All right, you got the point now, right? What's 1, 2, and 3? Right? Fluids, fluids, and fluids. All right, so Dinesh, there you go. If you're going to give so much fluids like I gave this guy, what are you going to give him now? To flush. All right, so you see, now you give the loop diuretics to get rid of the calcium because it has a calciuretic effect. Right? Be careful. Not in your boards, but in step 3, in the boards of medicine, they ask this question: how do you give furosemide in hypercalcemia? And the answer is, I give fluids, 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 and once the patient gets well hydrated, right, after a couple of liters, then I give the patient furosemide. Because look, if you write the order, give IV fluid, give furosemide, they're going to hang the fluids, they're going to push the furosemide, right? Patient's going to get more dehydrated, right? So you got to let them get hydrated with a couple of liters, then give them 20 milligrams or 40 milligrams of IV push. Okay? Everybody okay with that? So watch that. Watch that in clinical practice. Okay. So most people with IV fluids and furosemide are good to go, but sometimes you have cancers that are difficult to control. So you give them IV fluids, and then the cancer may come back. Okay, so what do? I give a combination of calcitonin and bisphosphonates. Okay, pamidronate, zanindronate, whatever you guys like. The reason I give them together is, look at here. Here's your calcitonin. So from day one, calcitonin, the effects of calcitonin, this is effect, percent of effects over time. Everybody see that? Effect, and this is time, right? So look at here. This is your calcitonin, right, at 2 days. Okay, so what do you notice? You give it right away, right, and your calcitonin kicks in right away, right? But Zia said it went down fast, so you get this thing called tachyphylaxis, right? So, the body gets used to it, right? But look at this now. What's this? This is the biphosphonate. Okay? So somebody asked a good question about giving oral loops. Listen, when we are in the hospital, remember, we want to control the environment as much as we can. We don't like to give oral stuff. We don't give oral loops in the hospital unless the patient is very stable, right? It takes too much time to act sometimes. So you can't control it. Then you sound like, did it work? Did it not work? Let me give him some more, and then you get like additive effects. So the two things that you don't want to do in the hospital: don't give oral hypoglycemics in the hospital. Don't give oral diuretics in the hospital. I mean loop diuretics. Okay? Everybody okay with that? So you guys notice here the effect of calcitonin and the effect of biphosphonates, why we give them together. See, so calcitonin goes away really quick after 2 days. By that time, biphosphonates have kicked in. Okay? And then biphosphonates, they could last last week sometimes. Okay? Everybody okay with that? All right, one more thing. So you guys feel comfortable about managing patients in the inpatient with hypercalcemia, fluid, then give them a little bit of loops. All right, start the calcitonin and biphosphonates right away, especially if this is cancer. Okay? Okay. I'm going to finish just talking briefly about hyperparathyroidism. So most of the times when we have hyperparathyroidism, this is the most common cause of parathyroidism, of hyperparathyroidism, of hypercalcemia. You have a single adenoma, right? So it kind of looks like this. See? You get this guy here. He secretes the PTH. He's the bad boy, right? And it's PTH that causes the effect on the bone. Here's the bone, right? The effect on the bone to do what? Activate the osteoclasts and release calcium, right? What does it also do? It reduces phosphate. Okay? So, but you guys notice this? Look at the other ones. What's happening to the other ones? The other three normal ones. That's in about 70% of the time. Atrophy, they're shrunken, right? Because they haven't lost their feedback loop, right? Everybody see that? So that's a single adenoma in about 70-75% of the time. Another 20-25% of the time, you have four-gland hyperplasia, and a very small percent of patients, about 2-3%, you could have parathyroid cancer. Okay, we need to know that hyperparathyroidism is associated with multiple endocrine neoplasias. The type 1, where you have hyperparathyroidism, pituitary tumors, and pancreatic tumors. Right? Watch this pancreatic tumor business. They like to ask about the association of pancreatic tumors with hyperparathyroidism. All right, so they're not talking about cancers of the pancreas. What are they talking about? What kind of tumors are they talking about, pancreas? Good, good. Gastrinoma or one of those secretory tumors, right? They're usually talking about a gastrinoma. So this patient has what? Zollinger-Ellison syndrome. All right, we'll talk about that. Zollinger-Ellison syndrome. A guy with hypercalcemia and diarrhea and peptic ulcer disease. Okay? And multiple endocrine too. They have hyperparathyroidism, pheochromocytoma, and medullary cancer. Right? That's the one that has the medullary cancer. Okay? Everybody okay with that? All right. Last thing. So we diagnose it with elevated PTH, the hyperparathyroidism. We find this elevated. What do? We send the patient to surgery. Okay? The definitive treatment of hyperparathyroidism is surgery. Okay? Unless the patient is older, has comorbidities, you can't take them to surgery, that's fine, and there's asymptomatic. Everybody else gets surgery. Okay? Everybody understand that? Be careful. Somebody told me about a young patient, 40-year-old woman. So remember, 40-year-old woman today will live at least another 40 years. So think about this. She's got hyperparathyroidism. You're going to leave it like that? Don't touch it? No. This is a surgical disease. Okay, before they do the surgery, do some kind of ultrasound or imaging study, an MRI or a nuclear scan of the neck to see what type you got. What do I mean, what type you got? Right here. Is it four-gland hyperplasia or is it one? Usually it's one, but you want the surgeon to know before you send the patient. Okay? I'm going to stop right there, and then we'll finish up talking about this tomorrow. I don't want to get into the next thing because we need a long talk about, we need to be fresh. Okay? Everybody okay with that? All right. This is an excellent class. All right. So the questions are great, which means that everybody understands that, right? Yep. Let me send you guys my email. Hey, don't bombard me. Give me until tomorrow to explain some stuff, okay? And then you could send as many emails as you want, okay? It's Charles.Faselis. Somebody was sending me an email. Charles Faselis is charles.faselis@gmail.com. Okay? Have a wonderful night, everybody. Thank you for your attention. And thank you, Dr. Aaron, Maggie, all the people that do all the other stuff behind the scenes. I don't see Mark there, but he was on there at some point too. All right? Thank you so much. All right. I very much enjoyed it. I'll see you all tomorrow. We'll finish up endocrine, right? All right. Have a good night, everybody. Good night, everybody.